Okay, I think we can start now. Esteemed jury, dear participants, listeners, ladies and gentlemen, on behalf of the Student Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in the International Medical Congress of Silesia 2024. My name is Aleksandra Nasiek, and I have an honor to coordinate the Systematic Review and Meta-Analysis Session 1. I would like to cordially welcome the esteemed jury, President of the jury, Dr. Marcin Miszczyk. And the members of the jury, Dr. Joanna Zembala-John and Engineer Daniel Cieśla. They are online with us. And we would like to explain the rules of the session. The order of the presentation will be the same as in the jury assessment sheet. The maximal time for the presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on to the conclusions and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. The assessment will be verified. I would like to remind that if the work is presented in English, the discussion also should be run in English. If the Commission will ask the question in Polish, the authors of the work are obliged to answer it in English. We kindly ask the jury to assess the scientific value, the way of the presenting, discussion, and own contribution. When the session ends, we kindly ask to give the cards back to the coordinator. Okay, so I think to begin, we can start with the first presentation with the title, How Does the Obesity Affect the Brain?
W jaki sposób mogę zmieniać slajdy tutaj?
Bardzo dobre pytanie. Tam są dwie osoby z działu technicznego.
Aha, okej.
Tu gdzieś jest przełącznik do slajdów. Zobaczysz.
Aha. Okay, więc mogę zaczynać? Okay, ladies and gentlemen, my name is Karolina Drgała and I'm a fourth-year medical student at the University of Rzeszów. Today I would like to present my work on the topic, how does the obesity affect the brain? And the aim of this study was to review available knowledge about the obesity impact on the brain. And to begin with, obesity is a disease characterized by an excessive accumulation of adipose tissue. Globally, the rate of obesity is rising at a never-seen-before proportions, and the full impact of the obesity has on the body's nervous system is still emerging. Brain dysfunction in obesity can be recognized as a result from neuroinflammation, oxidative stress, and change in gut-brain hormonal functionality. Obesity and metabolic syndrome have also been linked to a cognitive decline and plasticity and brain volume changes and alerted brain structure. Clinical data have shown that obesity is not only linked to cognitive decline, but also to other brain disorders such as dementia, anxiety, and depression. And due to the difficulty to dissect the impact of each component of obesity-associated alerted metabolism on neuronal performance, it is assumed that brain structural changes as well as the consequent cognitive impairment are the result of synergistic interplay between different obesity-induced risk factors. When it comes down to the brain structure, both gray and white matter and subcortical areas of the brain are changed. A higher BMI is associated with a decrease in various white matter regions, among others anterior and posterior thalamic radiations, inferior fronto-occipital fascicle, inferior and superior longitudinal fascicles, and reduction in gray matter volume in various areas, including the medial prefrontal cortex, bilateral cerebellum, and left temporal pole. The size of bilateral thalamus, putamen, and globus pallidus are also enlarged. Now moving on to the obesity-associated circulating factors. And abnormally high level of leptin plays a role in polygenic obesity, while low leptin is associated with weight loss from an obese state. Cross-sectional data suggests that inefficient leptin signaling is partly associated with changes in hippocampus structure and decrease in memory performance. In genetic obesity animal model with the leptin deficit, synaptic plasticity was shown to be impaired in the hippocampus. Rats with leptin deficit exhibit poorer performance in series of learning tasks as well as impaired synaptic plasticity in the hippocampus. Obesity is also associated with reduced levels of BDNF, or reduced BDNF signaling, which are associated with deficits in neuronal and behavioral plasticity. And the last one, obesity-associated circulating factors, adiponectin. Adiponectin plasma levels correlate inversely with obesity, insulin resistance, and type 2 diabetes. Adiponectin has been shown to regulate proliferation, neurogenesis, and branching of hippocampal neuronal stem cells. Several aspects of the brain function are affected by obesity-triggered inflammation. Periodic neuroinflammation is necessary defense for the brain. However, when it becomes prolonged or uncontrolled, it disrupts the normal protective barriers and leads to maladaptive synaptic plasticity and the development of different neurodegenerative disorders. Chronic inflammation has been shown to impair hippocampal neurogenesis and has also been linked to neurodegenerative disorders such as Alzheimer's disease. However, the role of inflammation in Alzheimer's disease is controversial because inflammation has been found to have beneficial role in the early stages of this disease. And to conclude, the causes and impact of obesity on overall health are a complex set of interactions. The evidence today suggests that obesity is associated with reductive cognitive function, plasticity and brain volumes, and alerted brain structure. Thank you for your attention.
Thank you for the first presentation. It's a very interesting subject. However, we also do have the name of a session which is called Systematic Reviews and Meta-analyses, and what implies a quite standardized method of presentation of the data. So let me start. You briefly indicated that there might have been some systematic review performed at the beginning of your presentations. Could you perhaps now specify how was it performed?
Could you repeat?
Yes, so systematic reviews are a very concise but also very precisely defined form of reviewing the available literature data. So could you elaborate on how was the systematic review performed? Because that's the name of the session.
Okay, so how I chosen the articles for this review?
How was the systematic review performed? Yes, so you start with searching the databases, you have some selection criteria, you have some search keys, and so on and so on. What I'm coming down to, I think it was a narrative review. So you identified a database and search the data, but not in a structured form. Is that correct?
Yes.
So then we have to identify it as a narrating review or a scoping review. Okay. So second of all, could you perhaps tell us about your own what was your part? What did you do in the review? What was your input? That's the word I was looking for.
Okay, so my input was searching the database, and choosing the criteria, which was the year of the articles from 2019 to 2024, and also only articles in English were chosen.
Okay. You said choosing the criteria. Could you tell us about the search criteria which you used?
Could you repeat?
Yes, you said that you. Oh, sorry. Maybe I was a bit. Maybe that was not loud enough. So you said you chose the criteria for the search strategy, right? Did I understand it correctly? So what were the criteria? How did you choose them?
Okay, so the criteria was, I mentioned before, the years, the language, and also the phrases which I used, which was I searched by using phrases the impact of the obesity on the brain and structural changes in the brain caused by obesity and cognitive function decline caused by obesity.
Did you use free text words? Did you use any structured ways of searching? You mentioned PubMed. It's not actually a database. The database is called Medline. It also includes EPUB ahead of print, Medline Central, and something called library. But in PubMed, you can use a couple of ways to search for data, right? You can search the whole text, abstract, title and abstract. You can search for mesh terms. Could you tell us which ones you used?
I searched for the abstract.
Okay, so title and abstract, free text words. Okay, thank you.
Thank you.
Okay. Are there any questions from Engineer Daniel Cieśla, maybe? If not, we can proceed to the next presentation, which is the benefit of the physical training in patients with depression. Yeah, and it's yours.
Okay, so in this work, I would like to say a few words about the benefits of physical training in patients with depression, and the aim of the study was to review available knowledge about this topic. And to begin with, depression is a serious condition that affects children, adolescents, and adults. Exercise, yoga, and meditation are among the non-pharmacological and non-conventional therapies that many people with anxiety or depression use. Physical activity interventions hold promise as an alternative approach to clinical treatment for depression. First, I would like to start with a few works on a given topic. Starting off with effectiveness on physical exercise in older adults with mild to moderate depression. Authors of this work decided to compare the effectiveness on physical exercise with that of treatment with antidepressant drugs, routinely used in clinical practice in terms of decreasing depressive symptomatology in patients aged above 65 years old who present with clinical criteria of a depressive episode. A total of 347 patients were divided into two groups, one in a supervised physical exercise program and two to receive antidepressant treatment by their general practitioner. Conclusions were that although improvement was initially similar in both treatment groups, antidepressant was superior in the medium terms despite giving rise to a greater number of adverse effects. And now moving on to the next one, physical activity and the prevention of depression, a cohort study. This study aims to identify the optimal amount and appropriate state of physical activity for reducing incident depressive symptoms. The data of 107,901 Korean adults who had undergone at least 2 annual health examinations from 2012 to 2015 were analyzed. In terms of 1 year changes in physical activity compared to the persistent sedentary group, the maintenance group was associated with a lower risk of development of depressive symptoms in both sexes. Women in the adoption group showed a positive effect in terms of decrease in incident depressive symptoms, and the conclusions from this study are that an optimal amount of physical activity for reducing the onset of depressive symptoms. In addition, maintaining an appropriate level of physical activity for 1 year proved beneficial for decreasing incident depressive symptoms. And the last study, physical activity interventions to elevate depressive symptoms in children and adolescents, a systematic review and meta-analysis. And the goal of this research was to determine the association of physical activity intervention with depressive symptoms in children and adolescents. 21 studies involving 441 participants were included. Physical activity interventions may be used to reduce depressive symptoms in children and adolescents. Greater reductions in depressive symptoms have derived from participants older than 13 years and with a mental illness or a depression diagnosis. The association with physical activity parameters such as frequency, duration, and supervision of the session remains unclear and needs further investigation. When it comes down to how physical exercise might affect depression, there are 3 possible ways, which among others include neuroplasticity. Evidence from human and animal studies suggests that depression is associated with structural abnormalities and dysregulation of some neuroplastic mechanism. Exercises stimulates many of the same neuroplastic mechanisms as is associated with growth in several brain regions that are adversely affected in people with depression, such as hippocampus, prefrontal, and anterior cingulate corticals. Several recent systematic reviews have found that exercise can increase the volume of both the left and right portions of the hippocampus and several cortical regions in healthy patients. And neuroendocrine system also has an impact of exercise on depression. When it comes to this system, hypothalamic pituitary adrenal axis hyperactivity and prolonged elevation of cortisol levels may contribute to the pathophysiology of depression, and exercise may help to negate these effects. However, there is a lack of research into the effects of exercise in the neuroendocrine system if people with depression, and results are mixed. When it comes down to inflammation, several meta-analyses have found exercises intervention can reduce a number of circulating inflammatory factors, including among others, interleukin-6, interleukin-18, and CRP leptin. And there are numerous lines of evidence to suggest that chronic low-grade inflammation may play a role in the pathophysiology of depression. And to conclude, the results of several studies suggest that physical activity interventions can alleviate symptoms of depression, and physical exercises have antidepressants impact due to a variety of biological and physiological mechanisms. Thank you.
Are there any questions from engineer Daniel Cieśla, maybe?
Hello, can I speak in Polish, please?
Yes, of course you can.
Prawdę mówiąc, mam pewien problem z oceną tej pracy, jak i poprzedniej, ponieważ nie do końca chyba spełniają te prace kryteria systemu przeglądu systematycznego, a tym bardziej metaanalizy. Zabrakło mi określenia, w jaki sposób prace zostały dobrane do tych opracowań, z jakich baz Pani korzystała, w jaki sposób prace zostały, jakie były kryteria wejścia, kryteria wyjścia, ile prac zostało odrzuconych, z jakiego powodu. To jest główny sens metaanalizy czy przeglądów systematycznych, żeby ocenić, całą literaturę, która jest dostępna na dany temat. Tutaj wygląda na to, że oceniła Pani kilka prac. No jakby brakuje całego opisu metodologii.
Rozumiem.
Także no myślę, że o to samo chodziło w poprzedniej pracy. No, jakby no trochę tutaj brakuje warsztatu takiego przeglądu systematycznego naprawdę pracy. To wymaga faktycznie dużej pracy, dużego opracowania i nie polega to na tym, żeby wyciągnąć kilka prac i zaprezentować niestety. Aczkolwiek no tak czy inaczej podziwiam zaangażowanie. Jednak tak jak mówię, no mam pewien problem z oceną.
Thank you very much. Are there any questions?
Niestety muszę się zgodzić z przedmówcą i to głównie było zastrzeżenie również do poprzedniej pracy, ale może, że pozwolę Pani się w jakimś innym kontekście wybronić. Niech nam Pani powie, jaki jest największy problem wybierania kilku prac i omawiania ich wyników zamiast stworzenia systematycznego przeglądu, który w strukturyzowany sposób, bo stąd jest ta nazwa systematic, który w strukturyzowany sposób pokazuje wszystkie wyniki prac na dany temat i nawet jeżeli wykonamy jego w systematyczny sposób, jakie dalej mogą być problemy z tym, jakie będą wnioski z naszego badania. Czyli innymi słowy, co by się poprawiło, jeżeli by Pani zrobiła w systematyczny sposób ten przegląd literatury, ale co jeszcze i tak mogłoby być problemem w raportowaniu takich rzeczy, jak na przykład wpływ ruchu na depresję.
To co by się poprawiło? Na pewno poprawiłoby się taka jakość tych badań, po prostu wnioski byłyby, że tak powiem, pewniejsze.
Ja tylko przerwę. Jakość badań by się nie poprawiła. Wybierając kilka przypadkowych prac, wybiera Pani te, które będą u góry wyszukiwania, te teoretycznie najlepszej jakości. Ale wybiera Pani również te, które są najbardziej popularne, najczęściej cytowane, czyli takie, które mogą mieć co bias, prawda? Bo ludzie najchętniej czytają prace, które potwierdzają tezę, którą już mają wcześniej w głowie i tak dalej. Więc innymi słowy, wybierając pracę w sposób arbitralny, mamy ryzyko wybierania prac, które wszystkie pokazują wyniki w jednym kierunku. A jeżeli to już ustaliliśmy, to jaki jest dalej problem, jeżeli nawet zrobimy ten systematyczny przegląd w kontekście tego konkretnego pytania? Jakim jest zysk z wysiłku fizycznego, z treningu pod kątem redukcji depresji?
Między innymi może być na przykład różnica tego wpływu w poszczególnych grupach wiekowych, w zależności od tego, jaki wysiłek fizyczny w ogóle jest wykonywany, jak intensywnie.
To jest heterogeniczność tak zwana. Tym sobie w pewien sposób radzimy w metaanalizach. Mamy ileś testów, I-square, tau-square, Q-Cochrana, mamy kilka modeli, które mogą tą heterogeniczność minimalizować, takie jak Random Effects Model, modele Bayesowskie, czy na przykład Generalized Linear Mixed Models. Ale jest coś jeszcze innego. Jest to temat popularno-naukowy, więc z czym może być problem? To tylko dokończę pytanie, z publikowaniem. Otóż w takich tematach i są dobre dowody naukowe na to, że najlepiej publikują się prace, które pokazują HR około 1,3 albo 0,7. To znaczy z 1000 prac napisanych opublikuje się powiedzmy 300-200, które pokazują taki wynik, jaki czytelnicy chcą przeczytać. Innymi słowy, jest ryzyko tego, że negatywne wyniki, nawet jeżeli dobrze metodycznie przygotowane są same prace, nie będą nigdy publikowane. Dobrze, dziękuję.
Dziękuję.
Thank you very much. And now I would like to address the next work, which is how stress affects the inflammatory bowel disease.
Okay, so ladies and gentlemen, my name is Natalia Bębenek and I'm a fourth-year medical student at University of Rzeszów. And today I would like to present a work about how psychological stress affects inflammatory bowel disease. To start, inflammatory bowel diseases, including Crohn's disease and ulcerative colitis, are chronic inflammatory diseases of not fully understood etiology or pathophysiology, associated with, among the others, diarrhea, anxiety, or unintentional weight loss. One of the factors associated with the development of IBD is psychological stress. The aim of this study is to review the available knowledge on the interaction between IBD and psychological stress from the literature available in PubMed scientific database. One of the research into IBD has revealed changes into brain-body connections that influence the gastrointestinal sensory and immune systems and has linked gastrointestinal pathologies to altered interoceptive processes. In animal models of colitis, it has been observed that psychological stress affects the gut's permeability, motility, sensitivity, and secretion, as well as the makeup of gut microorganisms, the establishment and reactivation of intestinal inflammation. Additionally, stress, anxiety, and depression have been implicated with IBD relapse and clinical deterioration in several clinical investigations. Compared to healthy people, IBD patients have an increased chance of developing depression. Chronic psychological stress causes the overproduction of adrenal glucocorticoids and corticotropin-releasing hormone, which in turn decreases the expression of tight junctions in the intestines, impairing the intestinal mucosal barrier's ability to function and has a direct correlation to advancement of IBD. Research has shown that mental stress counteracts the anti-inflammatory functions of the vagus nerve, lowering nervous tension and accelerating the release of inflammatory cytokines in many diseases, including IBD, treatment-resistant depressions, and post-traumatic stress disorders. Decreased vagal activity has been associated with systemic inflammatory symptoms in both Crohn's disease and ulcerative colitis patients, including increased production of TNF-alpha and C-reactive protein. How stress affects the body's immune and inflammatory systems usually depends on the length and severity of the stressor. Chronic inflammation is associated with a decrease in the number of macrophages, CD8 plus lymphocytes, and T cells, as well as with a subclinical increase in inflammation. Studies have shown that acute stress causes the lymphocyte population to shift rapidly and cause the leukocytosis that occurs in IBD. Acute stress may worsen gastrointestinal inflammation by reducing the diversity and abundance of a bacterial species, increasing colonization and amplification of pathogens such as Helicobacter pylori and Clostridium. Additionally, researchers found that changes in bacterial flora induced by restraining stress results in deficiency of the intestinal mucosal barrier protein mucin 2, which in mouse model impairs colonic mucus secretion as exacerbates colitis. These findings suggest that microbiota factors collectively contribute to the degeneration of the intestinal barrier. Clinical studies have shown that depression facilitates the migration of monocytes from the blood to the intestinal mucosa, which leads to the infiltration of macrophages into the colonic tissues and exacerbation of inflammation. It is possible that depression promotes the polarization of macrophages towards the M1 phenotype and accelerates the progression of IBD because CD patients with depression have greater numbers of M1 macrophages and higher levels of their secreted pro-inflammatory cytokines, and lower numbers of M2 macrophages and lower levels of their secreted anti-inflammatory cytokines. According to a recent study, long-term mental stress increased the levels of neutrophil chemokines, which in turn promoted neutrophil infiltration and mobilization into colonic tissues. As a result, colonic tissues secreted excess pro-inflammatory cytokines and exacerbating colitis in the DSS mouse model. Naturally, a wide range of other immune cells are also involved in the development of IBD, including innate lymphoid cells or natural killer cells. However, it has not been investigated whether these immune cells play a role in the process underlying the interplay between the development of IBD and psychiatric disorders. Stress can also cause changes in the behavior that increase the risk of disease flare-ups. According to a prospective population-based study, a significant stressful incident can trigger disease activation in the next 3 months. A multi-institutional study found that comfort anxiety and/or depression, which are typically associated with stress, were associated with a 28% greater risk of surgery in people with Crohn's disease. To conclude, stress can be linked to more severe symptoms, more flare-ups, and more hospitalization in IBD patients. It can therefore be assumed that psychological therapies as well as mindful-based intervention can potentially increase the effectiveness of the treatment of gastrointestinal diseases, thus improving the quality of life of patients. Some antidepressants, such as duloxetine, have also been shown to help elevate comorbid functional gastrointestinal symptoms in IBD, so it is worth delving deeper into the topic and discovering potential new therapeutic options. Despite understanding the basis of the relationship between stress and IBD, it is not known how often they co-occur or the exact causal relationship, so further research in this direction is needed. And thank you very much.
Thank you very much. Are there any questions?
Ja mam do Pani takie pytanie, bo ta praca nie miała charakteru przeglądu systematycznego ani meta-analizy, ale ta praca również, z tego co rozumiem, po prostu była przeczytaną prezentacją, prawda? Cały ten tekst był czytany. Nie robimy tak. Slajdy są po to, żeby przedstawić grafiki, czasami tabele, niewielkie ilości danych, ale na pewno bardzo mało tekstu, po to, żeby pomóc w naszej prezentacji, pomóc osobom słuchającym zrozumieć, o czym my mówimy. Ale absolutnie niedopuszczalna forma prezentacji jest to po prostu przeczytanie tekstu. To jest, mogłaby Pani otworzyć plik Worda i go przewijać w trakcie prezentacji. Efekt byłby taki sam, prawda? Dobrze. Czy jednak chciałaby się Pani spróbować obronić? Czy był tam element pracy przeglądowej? Czy w jaki sposób Pani zrobiła ten przegląd literaturowy?
Znaczy ja przede wszystkim szukałam takich artykułów, które będą jak najnowsze i skupiałam się na tych od 2021 do tego roku i skupiałam się na tym stresie takim psychologicznym, bo jednak wiele artykułów skupiało się na tym takim środowiskowym czy nawet tym oksydacyjnym. Dlatego chciałam się na tym takim psychologicznym, jak on wpływa jednak na całą tą chorobę.
A dlaczego Pani skupiła się na artykułach opublikowanych od 2021 roku? Czy uważa Pani, że wskaźniki zapalne to jest coś, co możemy mierzyć od 3 lat?
No nie, ale jednak nowsze dane to z reguły są po prostu lepsze.
Wydaje mi się, że jednak w nauce jest tak, że jeżeli uda się odpowiednio zaprojektowanym badaniem odpowiedzieć na jakieś pytanie, to nie zadaje się tego pytania jeszcze raz, prawda? Na przykład dalej stosujemy aspirynę u pacjentów.
No ale jednak medycyna dalej się rozwija,
prawda?
no to dlatego wydawało mi się, że jednak nowsze badania będą lepszą odpowiedzią.
Okej, ale niech mi Pani odpowie na to pytanie. Na przykład badanie, na podstawie którego podajemy aspirynę pacjentom z ryzykiem sercowo-naczyniowym, na przykład po zawałach. Czy ono jest opublikowane w ciągu ostatnich 3 lat?
No nie.
Nie, a w ostatnich 30 lat? Również nie. A czy podałaby Pani ten lek pacjentowi? Musimy uzasadnić. Każde kryterium ograniczające okres naszego wyszukiwania musi być uzasadnione. Jeżeli ocenia Pani parametry, które można oceniać od 50 lat, nie ma powodu, żeby sądzić, że akurat w ciągu ostatnich 3 lat dokonano przełomowych odkryć. A jeżeli Pani wie o tym przełomowym odkryciu, no to przestaje to być artykuł przeglądowy, a staje się artykuł popularno-naukowy. I to można na przykład na stronę Puls Medycyny napisać. Dobrze, ale no, wracam też jeszcze do 2 poprzednich prezentacji. Uważajcie na małe litery, w szczególności biały tekst na niebieskim tle na tej prezentacji jest nieczytelny, no ale właściwie można tylko zadać pytanie, czy to ma znaczenie, jeżeli Pani go i tak czyta. Dobrze, dziękuję.
Are there any questions? Engineer Daniel Cieśla, maybe?
No, thank you.
Okay, so thank you very much for the discussion. Okay, and I would like to ask the next presentation, which is Avoidant Restrictive Food Intake Disorder, a relatively new medical condition.
Okay, so good morning, ladies and gentlemen. My name is Monika Błądek, and I am a medical student from the University of Rzeszów. And today I would like to present a few words about avoidant and restrictive food intake disorder, which is a relatively new medical condition. To begin with, ARFID is a disease that may affect both children and adults, in whom it may be present from childhood on, or appear only in adulthood. Avoidant restrictive food intake disorder is a disease in which patient may avoid selected products due to their taste or the consistency. And the disease was first classified in DSM-5 in 2013, and it appeared also in ICD in 2022. The aim of the work was to review the available knowledge about ARFID. The paper presents a systematic review of the literature available in the PubMed, published over the last 5 years, and the search phrases used were ARFID and ARFID treatment. First, a few words about the epidemiology, and data describing the incidence of the disease vary and range between different sources from 1.5% to in primary centers to as high as 22% in specialized centers. And the main symptoms of the disease include avoiding food due to low appetite, sensory sensitivity, fear of choking, and avoiding food due to fear of choking and pain caused by ingested food or fear of allergic reaction, and also anxiety during eating. Significant food selectivity or limiting the amount of food consumed may result in significant weight loss and symptoms depending on what nutrient is missing in the patient's diet. In severe cases, patients may even be dependent on oral nutritional supplements or tube feeding. And here we have the slides which show the diagnostic criteria for ARFID. As we can see, it is an eating or feeding disorder which manifests as an inability to get adequate nutrients and or energy into the body. It must be accompanied by at least one of following, which is below. Significant weight loss or reduced weight compared to expected, nutritional deficiencies, dependence on additional forms of nutrition, or disorders in psychosocial functioning. This slide shows self-report questions to help make the diagnosis of ARFID. On the left, we have the EDYQ questionnaire consisting of 14 questions, and the NEIAS questionnaire consisting of 9 questions. Both methods are evaluated methods used in diagnosis of ARFID, and both questionnaires allows for the determination of the ARFID profile, and also EDYQ also allows for a differential diagnosis with other eating disorders. In addition to the tools shown, we can also use structural clinical interviews such as PARDI or EDE ARFID module. And the next issue is how to treat this disease. We can choose from the two main strategies. And symptomatic treatment in the patient condition requires it, and then treatment with psychotherapy. When it comes to psychotherapy, we distinguish between cognitive behavioral therapy and family-based treatment. And the main difference between these two therapies is who is treated. In the first case, we are dealing with therapy in which the patient himself takes part, and in the second case, the patient's family is also involved in the therapy. A review of the relationship between ARFID and ASD showed that the condition is a very common and important problem among children with the autism spectrum disorder, because many patients have all 3 main food avoidance factors listed in the guidelines. Due to the insufficient amount of literature on this topic, further research is needed to determine the incidence of ARFID in patients with ASD. ARFID is considered as a disease with a multifactorial etiology that is not fully understood. It is possible that biological, medical, or psychological factors contribute to it. While doing a review, I came across information about the study that is yet to be conducted, and we check whether there are any genetic determinants that may result in increased exposure to ARFID. However, we need further research on this issue and on other statological factors. And next, I wanted to talk about the differences. This slide. Next, I wanted to talk about differences about ARFID and other eating disorders. The most important difference is ARFID patients, unlike those with anorexia nervosa or bulimia, do not have a disturbed perception of their body image. And moreover, the population of people with ARFID is younger than the people with NNA, has longer presence of the disease before diagnosis, and is more often diagnosed with comorbid disease. And to conclude, ARFID is a disorder that significantly influences the person affected by it, and the patient with disorder should have different treatment depending on their condition. In the treatment of this disorder, a multi-directional approach is important, including psychotherapy and supportive treatment to improve the patient's quality of life. And that's all from me. Thank you.
Thank you very much for this work. Are there any questions?
Tutaj chyba tak jak i do poprzednich prac mam pytanie, jak została zebrana ta literatura, na jakiej podstawie te wnioski zostały wyciągnięte. Znaczy no w sumie pytanie, czy to naprawdę był przegląd systematyczny, czy to był...
No to tak, jeśli chodzi o moją metodologię, to jak wspomniałam wcześniej, tutaj użyłam wyszukiwarki PubMed i właściwie tylko z niej korzystałam. Użyłam fraz ARFID i ARFID treatment i chciałam się właśnie skupić na leczeniu tej choroby i objawach. Z moich wyszukiwań po wpisaniu tych fraz wyszło mi 44 artykuły i następnie przeanalizowałam abstrakty. I po przeanalizowaniu abstraktów wyłączyłam prace, które się powielały i do pracy włączyłam finalnie 10 artykułów, 11, przepraszam, które były dostępne w języku angielskim.
To może ja bym jeszcze miał jedno pytanie. Po wpisaniu tych kryteriów, które pani powiedziała, wyświetla mi się na PubMedzie 626 publikacji, aczkolwiek rozumiem, że pani postanowiła ograniczyć te publikacje do 5 ostatnich lat, prawda?
Tak, do 5.
A dlaczego, jeżeli to hasło pojawia się w literaturze dosyć regularnie i coraz częściej od 2011 roku, uważa pani, że te starsze prace nie są interesujące?
Tutaj przy tej pracy miałam dylemat, czy użyć jakby 5 lat, czy użyć tych 10, bo ta choroba została wprowadzona do klasyfikacji tam w roku 2013, jak wspomniałam wcześniej.
To jest 11 lat wtedy.
Tak, tak.
To można użyć. Nigdzie nie jest napisane, że trzeba używać ładnie wyglądających liczb.
No tak, ale jakby w tym przypadku uznałam, że jakby ten 5-letni okres będzie bardziej aktualny, ponieważ ta wiedza wcześniejsza będzie już jakby potwierdzona przez to, co zostało opisane już jakby w ciągu ostatnich 5 lat. Może to był błąd z mojej strony po prostu w doborze artykułów.
Być może był, ale może zostawmy to teraz, a wróćmy do tych kryteriów wyszukiwania. Powiedziała pani, że użyła pani 2 fraz, ARFID i ARFID treatment, prawda?
Tak.
Czego się pani spodziewa znaleźć, używając kryterium ARFID treatment, co by nie miało pola ARFID? Czy wie pani, jak działa to wyszukiwanie?
Przy wyszukiwaniu tego pojawiały mi się również inne artykuły, które nie były związane jakby specyficznie z tą chorobą, obejmowały inne zaburzenia odżywiania. Jakby przy odrzucaniu artykułów odrzuciłam artykuły, które nie odnosiły się specyficznie do tematu tego zaburzenia.
Dobrze, to ja może inaczej sformułuję to pytanie. Jeżeli z kryterium wyszukiwania ARFID i ARFID treatment usunie pani tą pierwszą część ARFID, czy zmieni się choćby jedna pozycja? Odpowiedź brzmi nie. A dlaczego? Bo w tym drugim jest zawarte te pierwsze kryterium, prawda? To ta wyszukiwarka sprawdza, czy to kryterium, które pani podała, znajduje się w artykule, ale częściej sprawdzamy jednak, czy znajduje się w tytule albo w abstrakcie. To jest znacznie lepszy sposób na ograniczanie naszych wyszukiwań niż na przykład wpisywanie takich dwusłowów. Jest coś takiego jeszcze, jeżeli chcemy to używać, jak proximity searching, bo może być na przykład jakieś słowo pomiędzy. No nie będziemy się zastanawiać dokładnie jako, ale tak samo treatment można sformułować inaczej. Można na przykład nutrition of patients with ARFID. Tak? Więc możemy używać tak zwanych proximity searching. Jeżeli potrzebujemy, żeby tam było to słowo treatment, to budujemy to wyszukiwanie tak, żeby one znajdowały się w jakiejś odległości, żeby zezwolić na te wszystkie permutacje, bo możemy to w wiele różnych sposobów sformułować. Okej. Dobrze. Dziękuję.
Thank you very much for this presentation, and I would like to present next paper titled How Vitamin D Deficiency Can Affect the Brain, a systematic review.
So here one more presentation from me. Now I would like to provide some information about how vitamin D deficiency may affect the brain. And the vitamin D is a vitamin that plays a significant role in the bone metabolism in the body. And as we already know, it also has many other different functions that have been the subject of numerous studies conducted in recent years. According to the literature sources, vitamin D affects the brain and nervous system. The aim of the study was to review the available knowledge on the impact of vitamin D deficiency on brain functioning, and articles available in the PubMed scientific database published within the last 5 years were used for the review, and the search was performed using the phrases vitamin D deficiency and brain dysfunction. First, some information about the substance that structures through which vitamin can act in the central nervous system. And the brain contains an important 1-alpha hydroxylase that can produce the active form of vitamin D and also has receptors for this vitamin. The active form of vitamin D can penetrate the blood-brain barrier, and its presence suggests that presence of catabolic pathway in CNS. Vitamin D may have neuroprotective effects through the production of neurotrophins. Also, it can regulate calcium metabolism in neurons through both genomic and non-genomic actions. In both cases, it affects L-type calcium channels. Vitamin D also increases the amount of substances such as glutathione or cytochrome C, which are antioxidants, and for this reason, deficiency in the brain causes an increase in the concentration of reactive oxygen form, which have negative effects. It is also suggested that the active form of vitamin D blocks nitric oxide synthetase in response to immunological or inflammatory factors. And in addition, oxidative stress can increase the level of CYP27B1, causing the local production of the active form of vitamin D, which mediates the neuroprotective effect of the substance. Many people around the world suffer from vitamin D deficiency. This group also includes pregnant women who are encouraged to supplement the vitamin D if it is needed. Although available data are not consistent, low vitamin D levels have been associated with adverse obstetric outcomes. Studies conducted on animal models showed that the hypovitaminosis in the mother causes changes in the structure and functioning of the offspring's brain, which affected memory and learning processes. And additionally, deficiency has been linked to an increased risk of neurodevelopmental disorders such as schizophrenia, autism, and ADHD. Moving on to the next effect, in the literature we can find more and more evidence that vitamin D deficiency plays a role in the progression of Alzheimer's disease. Low vitamin concentrations correlated with depressed mood and reduced scores on the mini-mental state examination test. Mechanisms that may influence neurodegeneration include prevention of oxidative stress, regulation of neurotrophic factors, and calcium homeostasis. Research also suggests that calcitriol alters cholinergic, dopaminergic, and noradrenergic neurotransmitters pathways in CNS, and vitamin D supplementation may improve cognitive functions in some patients. If we talk about the Parkinson's disease, then the exact protective mechanism of vitamin D of the development of PD is not clear, but many mechanisms of action have been correlated with neuroprotective effects. The active form of vitamin D stimulates the release of neurotrophins, inhibits the synthesis of nitric oxidase synthetase or TNF-alpha, and is involved in the production of many growth factors such as NGF, GDNF, and NT3. Now, it's not yet clear whether vitamin D is related to the severity of the symptoms of the disease, and has not been proven whether supplementation can be good support for pharmacological therapy. However, it is known that vitamin supplementation has a positive effect, slowing down deterioration of symptoms and considering the possibility of falls, reducing the number of fractures in patients, for example. As literature sources suggest that vitamin D deficiency may influence the development of depression, and 4 lines of evidence was proposed. The vitamin D receptors are located in various areas of the brain. People suffering from depression have lower levels of vitamin D. Vitamin D is involved in the regulation of the serotonin production pathways, and vitamin D modulates the immune response to stress. Studies have been carried out to check the effect of supplements as a preventive measure, and has been shown that the level of vitamin D during pregnancy was inversely correlated with the severity of depressive symptoms and depressive symptoms in the postpartum period, and positive effects were demonstrated in patients with vitamin deficiency. In some studies, especially on the population of older women, vitamin D supplementation did not bring any improvement in depressive symptoms. To conclude, vitamin D plays an important role in many different processes occurring in the human body. Its appropriate concentration is necessary for the proper functioning, not only for the skeletal system, but also the brain and nervous system. The appropriate concentration of vitamin D plays a significant role in the functioning of the human body at every stage of his life, from prenatal to old age.
Thank you very much for the presentation. Are there any questions?
Mogłaby Pani przedstawić, w jaki sposób doszła Pani do bazy danych tych artykułów? Ogólnie przynajmniej przybliżyć nam, w jaki sposób przeprowadziła Pani tą analizę, przegląd systematyczny.
No to tutaj podobnie jak w poprzednim przypadku użyłam wyszukiwarki PubMed, używając fraz, o których wspomniałam wcześniej, vitamin deficiency and the brain dysfunction. W tym momencie nie pamiętam dokładnej liczby artykułów, ale przeanalizowałam artykuły, wybrałam te w języku angielskim i po odrzuceniu wstępnych abstraktów do analizy zostało włączone kilkanaście artykułów, skupiających się głównie na tematach, które poruszyłam w tej prezentacji, czyli też jakby w trakcie wykluczania wykluczyłam tematy odnoszące się do innych obszarów, na które może działać witamina D w kontekście układu nerwowego i mózgu.
Tutaj do tej pracy oczywiście mają zastosowania poprzednie nasze uwagi, więc jakby chyba nie będziemy ich powtarzać, ale oprócz tego przepraszam, bo nie jestem lekarzem po pierwsze, po drugie, jeżeli chodzi o mózg, nie mam doświadczenia w pracy na ten temat. Głównie pracuję z kardiologami. Jednak wydaje mi się, że tutaj teza jest troszkę zbyt szeroka tak naprawdę. Jak witamina D wpływa na mózg i przedstawia Pani dużo różnych obszarów, na które wpływa. Tutaj raczej w takim przeglądzie systematycznym postawiłbym węższą tezę i skupiłbym się na tym, żeby to udowodnić bądź zaprzeczyć, pokazać jak to wygląda w literaturze. No tutaj tak naprawdę, tylko tak jak mówię, nie mam doświadczenia w tej materii, więc nie wiem, być może to są rzeczy, które się ze sobą bardzo łączą, aczkolwiek no jak dla mnie to jest szeroko mocno. Ale dziękuję bardzo.
Zgadzam się z poprzednimi komentarzami. Również chciałbym jeszcze dodać z mojej strony. Wybrała Pani w tym momencie, o ile przy poprzedniej pracy mogliśmy dyskutować na temat tego, czy to jest 10 lat, 15 i tak dalej, to witamina D jest troszkę starszym wynalazkiem, prawda? Ona
tak.
pochodzi z początku XX wieku, już minęło ponad 100 lat od jej wynalezienia i wydaje się, że również jest jeden problem z prowadzeniem takich badań, dlaczego być może te badania nie pokazałyby się w ostatnich 5 latach. Abstrahując od tego, jeszcze raz, ja Państwa uczulam, dobrze wykonanych badań naukowych się nie powtarza. Prawdziwi naukowcy czytają, co było w literaturze do momentu, do którego oni zadali swoje pytanie. Jeżeli ta odpowiedź jest w literaturze, to nie zadają tego samego pytania jeszcze raz, ze względu na to, że szkoda na to pieniędzy i czasu. Ale jakby Pani zaprojektowała takie badanie, które by weryfikowało, czy niedobór witaminy D, nie suplementacja, czy niedobór witaminy D wpływa na pracę mózgu i dlaczego takie badanie być może kiedyś dało się przeprowadzić, a teraz już będzie trudno?
Projektując takie badanie, na pewno trzeba było zebrać grupę badanych i też pytanie, na jakim modelu po prostu przeprowadzić badania, czy badania na modelu zwierzęcym, bo na ludzkim trochę nieetyczne, tak według mnie. No załóżmy, założyć sobie jakąś grupę, wykorzystać informacje, które już wiemy wcześniej i sprawdzić tą tezę po prostu na działania witaminy D, jakby braku na mózgu. Nie jestem pewna, czy do końca zrozumiałam dobrze pytanie jakby z projektowaniem.
W pewnym sensie, powiedziała Pani kluczowe słowo, etyka, prawda? Komisja biotyczna
tak.
mogłaby nie wyrazić zgody na przykład na to, żeby sprawdzać, co się dzieje u kobiet z niedoborem witaminy D w trakcie ciąży. Ale być może bylibyśmy w stanie historycznie zidentyfikować populacje, w których był niedobór witaminy D. Na przykład w naszym rejonie. Czy jest Pani sobie w stanie wyobrazić taki moment w historii, kiedy można by takie badanie przeprowadzić? Nie jest on teraz. Teraz byłoby nieetyczne obserwowanie ludzi z niedoborami witamin, jeżeli o nich wiemy. Ale kiedy by to było?
To teoretycznie można by było się posiłkować danymi z, nie wiem, tak teraz do głowy mi przychodzi jakiś okres wojenny, gdzie były jakieś tam niedobory witamin ogólnie, składników pokarmowych, ale...
Wojna była straszna, ale akurat słońce świeciło wtedy tak samo jak teraz.
Ale właśnie jest słońce, które
tak, populacje na przykład
D,
górników i hutników w Rudzie Śląskiej w Bytomiu, prawda? Czyli osoby, które pracowały większość czasu pod ziemią i jeszcze wtedy był drugi problem, ogromne zanieczyszczenie powietrza, które zdecydowanie zmniejszało oświetlenie tych rejonów, prawda? Więc takie badanie można by na przykład przeprowadzić w latach 50., 60. Dobrze, dziękuję.
Bardzo. Dziękuję.
Thank you very much for the presentation, and I would like to ask the presenter of the paper Gut Microbiota and Anorexia Nervosa, Therapeutic Perspectives.
Thank you for the opportunity to speak at this Congress. My name is Sofia Spandel, and I would like to present my review titled Gut Microbiota and Anorexia Nervosa, Therapeutic Perspective. The human body is inhabited by nearly 3.3 million genes of microorganisms. Furthermore, it's estimated that our digestive system is populated by 300 to 500 species of bacteria with a mass exceeding even 2 kilograms. But just the microbiota can be defined as the complex of bacteria, fungi, archaea, viruses, and protozoa. Also, microbiota changes and is shaped by various factors, including nutritional status. That's why this review aims to analyze scientific studies based on the relationship between the gut microbiota and eating disorder, which is anorexia nervosa, but with a therapeutic perspective. So we analyzed the results of animal and human studies in different health conditions using specific search phrases such as microbiota, gut, and anorexia nervosa. In PubMed, we obtained over 880,000 records after considering selected criteria, including English or Polish language, articles published after 2015, and open access. We narrowed it down to 111 sources. And special attention was given to the latest scientific studies from the past 5 years, which constitute over 25% of cited sources. Thanks to this review, we noticed the highest frequency of bacteria in the intestines of patients with anorexia compared to healthy ones. For example, Methanobrevibacter smithii is responsible for using food as an energy source for the body, so a higher number of these bacteria could be adaptation for the low-calorie intake. Additionally, it has been confirmed that Escherichia coli can produce protein CLPB, which triggers the production of antibodies to react with appetite regulation hormone, creating the feeling of satiety. Studies have also shown a higher level of mucin degraders, such as Clostridium, and higher occurrence of potentially pathogenic bacteria, such as Klebsiella and Salmonella. Also, we saw the lower frequency of occurrence of bacteria in the patients with anorexia compared to the healthy ones. So, for example, this is associated with decreased concentration of short-chain fatty acids, such as butyric acid, that maintain energy sources for colonic epithelium cells, which is the main factor in microbiota. Also, propionic acid, responsible for regulating blood glucose level, and acetic acids that prevent the growth of pathogenic bacteria by changing pH in the intestine. I would like to highlight that the most studies are focused on the Escherichia coli and CLPB protein. And this protein mimics the alpha MSH antigen with anorectic effect that gives the effect of satiety. The level of this protein in the serum depends on its concentration in the gut microbiota. And as a result, increased numbers could be associated with CLPB. And seeing the correlation between the microbiota and eating disorder, we took a step further and researched the details of its modulation. So it has been shown that the microorganisms in the intestine are strongly dependent on the composition and type of the host diet. In the first line, we see the bacteria that can influence the physiology of the host body, for example, by control intestine transit time. They take part in the regulation of neuropeptide expression, and also they are a source of short-chain fatty acids, as I mentioned before. There is also evidence on the influence on mood and cognitive function. For example, Bacillus mediates the synthesis of norepinephrine and dopamine, while Lactobacillus additionally synthesizes acetylcholine. Furthermore, in 2019, it was confirmed that increased serotonin production from tryptophan leads to reduced back depression inventory scores after administration of Lactobacillus helveticus and Bifidobacterium longum in patients taking antidepressants. And to conclude, the correlation between gut microbiota and anorexia nervosa does exist. And moreover, it was found that such an interaction regulates multiple mechanisms responsible for maintaining the host homeostasis. So the presence of individual microorganisms in the intestine is strongly dependent on the host's health status. But however, it remains unclear whether the observed microbiological changes in patients are a consequence of chronic calorie restriction or a causative factor. Also, the immunization against CLPB can be considered as a potential preventive and the therapeutic option, such as probiotics, are one of the ways to manipulate the gut microbiome. But I would like to highlight that it's still important to continue research to the implementation of probiotic therapy in the treatment of eating disorders and to educate society of maintaining a lifestyle that promotes the healthy gut microbiome. And thanks for your attention.
Thank you very much for your presentations. And are there any questions? And we would like to say hello to Dr. Zembala John, who is now online with us also.
Hello, thank you. Very good presentation.
Thank you.
Ja bym może chciał zacząć od pytania na temat pani Search Strategy, bo tam pojawia się takie stwierdzenie, że 880 000 artykułów było.
Tak, rekord.
Co pani zrobiła z tym 880 000? Nie uwierzę, że ktoś się przeglądał.
Tak, dlatego że wyszukiwałam po kolei według słów kluczowych i spisywałam mniej więcej dokładnie ilość rekordów, które zostały odkryte. Natomiast, tak jak wcześniej wspomniałam, po zastosowaniu włączonych kryteriów i utworzeniu kolejnych filtrów udało mi się uzyskać około 111 rekordów, którymi byłam zainteresowana.
Jasne. Prisma Flowchart pierwszą rzeczą, którą raportujemy, to jest właśnie to, czyli ile udało nam się rekordów znaleźć po zastosowaniu kryteriów wyszukiwania. Dobra? Jest taka część Prisma S, czyli Prisma for Searching, gdzie raportuje się w Search Strategy dla osobnych haseł, ale to nie jest raportowane na pewno na prezentacji. To jest w supplementary file w artykule. Na końcu w Conclusions pojawia się informacja o tym, że na pewno jest związek pomiędzy florą bakteryjną jelit a anoreksją. Czy jest Pani w stanie powiedzieć parę słów więcej na temat tego, jakie mamy dowody na to, że A wywołuje B, a nie B wywołuje A?
Jasne. Tak jak wspomniałam, przez to, że mikrobiota jest bardzo kompleksowym zagadnieniem, bardzo ciężko jest stwierdzić, co było przyczyną, a co jest skutkiem. Natomiast dzięki temu, że to jest przegląd systematyczny, autorzy danych meta-analiz czy randomizowanych badań już określili tam swoje stanowisko, na którym ja bazowałam. Natomiast jeśli chodzi o to, co ja sama wyciągnęłam z tego badania, to sama anoreksja jest zagadnieniem, które jest stosowane w psychodietetyce i nie do końca jest w stanie nawet DSM-5 czy ICD-10 zdefiniować sam ten fakt. Więc jeśli chodzi o ten związek, co jest A, a co jest B, a co B, a co A, tutaj należy bardzo podejść indywidualnie do pacjenta, do jego wyników badań i dokładnie przeprowadzić wywiad w ramach tego, żeby po prostu wyszukać czynniki, które mogą na to wpłynąć. Najważniejsza tutaj jest indywidualizacja, tak samo później w terapii. Indywidualizacja terapii, leczenia czy podejścia dietetycznego.
Okej. Jeszcze jedno pytanie. Jeżeli już zbliżamy się do formy, jaką jest Systematic Review, którą jeszcze to nie było Systematic Review, ale idziemy w tamtym kierunku, to moje pytanie jest takie. Jedną z kluczowych rzeczy tej formy jest to, że wszystkie etapy robione są przynajmniej przez 2 osoby niezależnie i następnie trzecia osoba lub cały zespół badawczy sprawdza rezultaty i rozwiązuje ewentualne konflikty. A więc czy to wyszukiwanie literatury i przeglądanie artykułów było wykonywane przez Panią, czy ktoś jeszcze w tym pomagał? Niezależnie to robił, a później była synteza Waszych wyników.
Tak jak jest wspomniane, albo było wspomniane na pierwszym i ostatnim slajdzie, opiekunem mojej pracy była pani dr Karolina Kropokotara, więc w momencie, w którym ja wyszukiwałam dane artykuły, również z nią konsultowałam, czy taki artykuł powinien zostać zawarty.
Czyli nie było to zrobione, bo chodzi o to, żeby to 2 osoby zrobiły niezależnie i dopiero później były te wyniki połączone. Czyli to nie było zrobione?
Nie.
Dobra, dziękuję.
Dziękuję bardzo.
Thank you very much for the presentation, and I would like to now present the next work, which is Understanding Seasonal Trends in Depression and Anxiety, Insight from Adolescents to Adults. Okay, we have the presenter.
I hope you can see both me and my slides. So hello, I'm Gabi Evans-Lovaite from Vilnius University, and along with my colleague Ieva Vanagaite, we made a literature review of Understanding Seasonal Trends in Depression and Anxiety, Insights from Adolescents to Adults. Anxiety and depression are types of mood disorders. Among other things, depression causes feelings of sadness, hopelessness, and reduced energy. Anxiety creates feelings of nervousness, worry, or dread. Although the 2 conditions are different, you can have both at the same time. Both of these mood disorders are rather common worldwide. 301 million people worldwide suffer from anxiety disorders, making them the most frequent mental disorder, while other 280 million people worldwide suffer from depression. Women are more likely to experience anxiety and depression than men. In recent years, it has been noticed that seasonality patterns have been reported in various psychiatric disorders, including depression and anxiety. Therefore, understanding seasonal patterns in these disorders in adolescence and adulthood could be vital for new and advanced future mental health interventions. The aim of the study was to investigate seasonal trends and connections in adolescent and adult depression and anxiety. The PubMed database was used for the literature review, covering articles from 2013 to 2023. The following English keyword combinations were used for this research: mental disorder, mental disease, mental illness, seasonality, adult, and adolescent. 66 articles were found, and 20 of them were included in the literature review after reviewing and excluding ineligible publications. Results. Research indicates a higher prevalence of depression among adolescents during winter compared to summer. The incidence of depression in this age group typically decreases from January to August, only to surge and reach its peak in November. Antidepressant prescription shows peaks in spring and autumn for both genders, while remaining relatively stable during summer. It was also noticed that adolescent females received prescriptions more frequently than the males. Furthermore, the highest levels of anxiety are reported between September and November in the age group of between the ages of 14 to 18. Depression among adults. The highest incidence of all types of depressive disorders in adults occurred during late autumn and early winter. Mild depressive episodes peak in November, while moderate and severe episodes without psychotic symptoms are most common in October and November. Bipolar depression peaks in November, and severe depression with psychotic symptoms peaks in December. Additionally, a slight increase in the incidence of unipolar depression is observed in spring, especially during April. Those with bipolar depression report experiencing a significantly heightened impact of seasonality. Antidepressant prescription rates are highest during the winter months. Seasonality notably impacts depressive symptoms in the middle-aged women and older adults, more than 50 years old, with depression caused seasonality peaking in winter and decreasing in spring. Furthermore, the highest incidence of anxiety disorders is observed in November, while the lowest is in July and August. Our conclusions would be that the various studies have observed some seasonality-related trends in the onset and exacerbation of mental disorders, but the research results so far are rather contradictory. Further in-depth research is needed to better understand the impact of seasonality on mental health. These are our references, and thank you for your attention.
Thank you very much. Now let's move to the discussions. Are there any questions?
I guess we did perform some of the discussion previously in Polish, so let me translate it to English. We are in this session. We are supposed to rate systematic reviews and meta-analyses, and also with your presentation, there is an issue that it is not a systematic review, right? Because a systematic review follows a very well standardized form, and thus requires several steps to be called that, and meta-analysis is just a further version of systematic review. So perhaps you could tell us a bit more about the methodology and how you performed the literature review, so we can further evaluate it.
Well, the literature review was performed in PubMed database, and we used keywords like seasonality, adult, adolescent, child, mental disorder, mental illness, and afterwards we chose free full text in English. And first we reviewed the articles from the name only. After we removed the articles from the name only that were not suitable, we moved to the abstracts. After reading through all the abstracts, we removed those that didn't mention any mental illnesses or mental disorders. And afterwards, from those remaining 66 articles, we only, after reading through all the articles, we only left the remaining ones that mentioned depression and anxiety. So those were 20 articles that were left for us.
Did you follow any particular guidelines for selecting articles or for conducting research?
Yes, we excluded all
guidelines. And did you follow any specific guidelines on how to conduct a research strategy or how to extract the articles?
Yes.
Which one?
The PC guideline, that is, I believe it's called.
No such guidelines. Maybe you can think of another name.
I'm sorry, right now I can't
remember
the specific name, because when excluding the articles, we discussed with our tutor, and right now I can't remember the exact name of it.
Sure. Why did you only use one database? That actually applies to all previous presentations too, but why did you only use one database? Or actually, that's not a database. PubMed is not a
we
database.
Didn't only use this database. Yeah. We used Google Scholar too, but afterwards, when comparing the Google Scholar and PubMed database, we found out that we actually came up with, after excluding all the articles, that the same articles were left for us in both in Google Scholar and in PubMed, so we decided just to use the PubMed database.
Neither PubMed nor Google Scholar are databases, but that's not so important. Google Scholar is a scatter and search type of search engine. It provides an infinite amount of results. So how many results were included in the combined search?
In the combined search?
Yes, you have to choose a specific number of 100. Records you want to extract from Google Scholar. It will search at infinity, if not provided a specific number. How many?
132.
Oh, that's a very specific number. Okay. Thank you.
Thank you very much for your presentation.
If I may, we had a objective, but maybe that policeman, I'll be the good one. And I think I'll be a little bit I'll play a role of an advocate. I believe that we will have quite similar presentations today. I think a lot of our students, and maybe it's our fault also, don't know exactly what is a systematic review and what is a meta-analysis and how to perform it according to the standards and according to the PRISMA. I was very surprised actually when I saw so many systematic reviews during this session, because it's really something very demanding, very difficult, I would say. So I think we will have to prepare and not stress our future also presenters, and that those systematic reviews will not be performed according to PRISMA. But a lot of work is done, and I think we will get there at some point.
Thank you for your comment. And I would like to ask the next presenter, which is seasonal patterns in adult bipolar disorder. Okay, you can start if you are ready.
Yes. So I will present again seasonal patterns in adult bipolar disorder. Bipolar disorder is also known as bipolar affective disorder, and it is one of the top 10 leading causes of disability worldwide. Bipolar disorder is characterized by chronically occurring episodes of mania or hypomania, alternating with depression, and is often misdiagnosed initially. The aggregate lifetime prevalence of the bipolar spectrum is 2.4% of the whole human population. Bipolar disorder is often difficult to recognize because symptoms overlap with other psychiatric disorders. Psychiatric and somatic comorbidity is common, and patients may lack insight into their conditions, particularly during hypomania phase. Treatment involves pharmacotherapy and psychosocial interventions, but mood relapse and incomplete response occur, particularly with depression. So understanding the seasonal patterns present in adult bipolar disorder is crucial for refining and optimizing mental health treatment strategies, ensuring more targeted and effective interventions for individuals with this complex condition. The aim of the study was to investigate seasonal patterns and their causes in adult bipolar disorder. The PubMed database was used for the literature review, covering articles from 2013 to 2023. The following English keywords combinations were used for this research: mental disorder, mental disease, mental illness, seasonality, adult. 66 articles were found, and 5 of them were included in this literature review after reviewing and excluding ineligible publications. Results. There are 2 types of bipolar disorder. Type 1 is diagnosed with at least 1 marked manic episode, and the mania episode tends to last more than a week, while the depression tends to be milder than in other bipolar types, while some patients experience no depression. While type 2 bipolar disorder is diagnosed with recurrent episodes of depression and hypomania. Mania symptoms usually show up as a milder form of mania that lasts at least 4 days, while depressive episodes are broken up by periods of hypomania. Up to 25% of individuals with bipolar disorder experience seasonal patterns of symptoms. In this disorder, manic episodes tend to occur in the spring and/or summer, and depressive episodes in early winter. Mixed affect is most prominent in early spring or mid to late summer. Some studies have shown that young adults show greater seasonality of symptoms compared to middle-aged individuals. It has been hypothesized that the frequency of manic episodes is related to the length of the day and amount of sunlight. The mechanism of action of this hypothesis is explained by the fact that the rapid increase in light during the warm seasons stimulates the pineal gland, leading to a decrease in melatonin secretion and the onset of manic episodes. Along with the rapidly increased photo period, there is a peak in the overall diagnosis of unipolar depression and bipolar depression episode in April. The explanation for this paradox may be that the abruptly and rapidly increasing light exposure after the cloudy and dark period of the year, especially at the northern latitudes, acts as a trigger for depressive feelings, which deepen among those who are already depressed and suffering from bipolar disorder, whereas longer-term exposure to light during the summer enhances mood in general. It seems that in the depressed, physiological responses in the brain and skin induced by the exposure to light might be due to varying extent abnormal when compared with those in healthy individuals. The seasonality is thought to have a greater influence in women with bipolar affective disorder than in men, and this might be related to the strong link between the female reproductive hormonal axis and the regulatory mechanisms of sunlight sensitivity. However, more research should be made for this. When assessing the seasonality of bipolar affective disorder by type, it was observed that in both type 1, which is diagnosed with at least 1 marked manic episode, and type 2, which is diagnosed with recurrent episodes of depression and hypomania disorders, depressive symptoms were lowest in the summer and highest in the beginning of winter. The increase in depressive symptoms in winter was significant only in type 1 bipolar affective disorder, whereas in type 2, the increase in hypomanic symptomology was significant and was observed in early autumn. Seasonality is a characteristic of both types of the disorder, but it was significantly more frequent in patients with bipolar type 2 disorder. Geographical areas with 4 seasons are more likely to have bipolar affective disorder as the first episode of depression due to the unequal amount of sunlight received per year. This is also the case in patients living in tropical climates, where the most important variation in the amount of light is between the wet and dry seasons. The risk of suicide and self-harm in people with bipolar disorder is estimated to be as much as up to 20-30 times higher than in the general population. Suicide attempts in patients with type 1 bipolar disorder have been associated with living in geographical areas where the amount of sunlight varies significantly between winter and summer. Conclusions. Seasonal patterns in bipolar disorder, particularly in manic and depressive episodes, are influenced by increasing daylight length, with geographical factors such as distinct climates also playing a role in the onset, highlighting heightened suicide and self-harm risks in regions with significant sunlight variations between seasons. Thank you for your attention, and this is our references.
Thank you very much. Let's move to the discussion. Are there any questions?
If I understood correctly, you started your work, this work and previous one has a common fundament, right?
Yes, we started searching through all the mental disorders mentioned while searching for those mental disorders, and we chose only to publish here for the anxiety and depression and adult bipolar disorder. But in Lithuania, we published a paper in scientific paper published for the seasonality of mental disorders from the children to the adolescents to the adults that we have. But we chose to showcase the most interesting ones here.
Okay, I understand. Congratulations for the paper, and also congrats for paying attention to the geographical area and climate. That was my question from the beginning, but you answered that question. That's very important to consider that in this analysis. Okay, thank you. Thank you so much, and good luck with your work.
Thank you.
Okay, so thank you very much for your presentation. And I think we can move to the next one, which is the role of aldehyde dehydrogenase in chemotherapy resistance in non-small cell lung cancer.
Hello, everybody. I'd just like to ask if I can be heard well.
Yeah, you are heard well. Yeah.
Yeah.
Please upload your presentation to the full screen.
Okay. So is everything all right?
Yes, everything is correct. If you are ready, you can start.
Yeah, so welcome, ladies and gentlemen. My name is Ernest Borkowski. I'm a first year medical student at the Medical University of Łódź, and I prepared a presentation on the role of aldehyde dehydrogenase in the chemotherapy resistance in non-small cell lung cancer. Firstly, I'd like to touch on the fact why I even chose to talk on this topic. Well, to put it briefly, lung cancer remains the leading cause of cancer deaths in the world, including Poland. According to data from Global Cancer Observatory, in 2022, it ranked the first amongst all cancers when it comes both to incidence and mortality, just as we can see on the figure. Furthermore, about 80 to 85% of total lung cancer cases are non-small cell lung cancer. What's important is that this histologic subtype of lung cancer has a tendency to be diagnosed, first of all, late, making surgical treatment oftentimes not a viable option, and also to develop chemotherapy resistance, which remains a significant problem in treatment. When it comes to materials, we used the PubMed and Google Scholar databases, limiting the article searches to the years 2019 to 2024. And the aim of this review is to basically establish the contribution of this enzyme, aldehyde dehydrogenase, to cancer progression and chemotherapy resistance in NSCLC. Just as we can see on the figure, aldehyde dehydrogenase plays a variety of roles in cancer cells. The ones that I'd like to focus on, however, are it's acting primarily as an aldehyde dehydrogenase and an anti-stress protein factor. In cancer cells, aldehyde dehydrogenase contributes to detoxification by converting endogenous and exogenous toxic aldehydes into much less toxic and better tolerable carboxylic acids. Also to antioxidation by scavenging and eliminating reactive oxygen species, and also indirectly by regenerating glutathione. Aldehyde dehydrogenase is also involved in several metabolic pathways by the generation of NADH, And what's also very important is its contribution to signaling in cancer cells, because aldehyde dehydrogenase metabolizes all trans and 9-cis retinols into retinoic acids, which are crucial signaling molecules for the differentiation of cancer stem cells, which we will talk about in a minute. In general, we can conclude that aldehyde dehydrogenase promotes cancer stemness. The role of these cancer stem cells in chemotherapy resistance and the rise of invasiveness in cancer progression is quite big. As we can see on the diagram in a simplified manner, the use of a chemotherapeutic such as cisplatin, let's say, can eliminate the majority of cancer, of regular cancer cells. Even then, however, a small group of them called cancer stem cells will survive and then proliferate, causing the formation of a invasive and very chemoresistant secondary tumor. And what's crucial in all of this is that aldehyde dehydrogenase contributes to the phenotype of these cancer stem cells to a major degree. As I already said, aldehyde dehydrogenase overexpression, so high expression, is related to increased invasiveness and chemoresistance. We can basically say that aldehyde dehydrogenase, that high expression of this enzyme, acts as a potential biomarker of these invasive cancer stem cells. As we can see on figure 5, a comparison between A549, which is a non-small cell lung cancer cell line, and its cisplatin-resistant subtype. Here we can clearly observe that the expression of aldehyde dehydrogenase is much greater in the cisplatin-resistant cells. And on the right, also a comparison of normal versus cancerous lung tissue, clearly showing that the expression, that the level of this enzyme in cancerous tissue is much greater compared to normal lung tissue. In normal pneumocytes, the expression of aldehyde dehydrogenase is very low and oftentimes even undetectable. Furthermore, aldehyde dehydrogenase overexpression also correlates with epithelial to mesenchymal transition, EMT. This transition is also crucial for many of the characteristics of cancer stem cells, mainly their motility and the ability to migrate and form metastases. As we can see on figure 7, the expression of several EMT markers, in this case encadherin, vimentin, and snail, is greater in the cisplatin-resistant cells compared to the regular cancer cells, which is also indicated by figure 8. In this particular case, in terms of morphology, we can see that the cisplatin-resistant cells resemble mesenchymal cells much more than they do typical epithelial cancer cells, because they are more irregular in their shape. Aldehyde dehydrogenase overexpression also contributes to ATP production via the already mentioned generation of NADH. Therefore, aldehyde dehydrogenase can participate in energy generation in cancer cells, which is also indicated by figure 9, showing that the use of aldehyde dehydrogenase inhibitors such as gossypol can reduce the amount of ATP and NADH in cancer cells, non-small cell lung cancer cells. A question therefore arises: couldn't we potentially use inhibitors of aldehyde dehydrogenase as chemotherapeutics or adjuvants in chemotherapy? Well, we can, and there are already numerous substances being researched in terms of their use in this context. For example, disulfiram, which is a well-known anti-alcoholism drug, acts as a irreversible aldehyde dehydrogenase inhibitor, or also isothiocyanates, which are substances generally found in vegetables, substances of natural origin, but which can also be synthesized. As shown on figure 7, the use of these substances, so disulfiram and isothiocyanates, combined with cisplatin, enhances the cytotoxicity of this cisplatin, so of the chemotherapeutic, towards non-small cell lung cancer cells. Another potential inhibitor of aldehyde dehydrogenase is a substance called diamate, which effect on non-small cell lung cancer we can see in figure 11. In this particular case, these were mice with inserted non-small cell lung cancer xenografts and then treated with diamate. And as we can see, according to the bioluminescence, the use of this drug caused regression of tumor growth. In conclusion, aldehyde dehydrogenase protects cancer cells from oxidative stress, from toxic compounds, so it acts as a cytoprotectant. It also contributes to metabolic pathways and the differentiation of cancer stem cells, of which aldehyde dehydrogenase is a potential biomarker. So it indicates that these particular cells are aggressive in their phenotype. Therefore, inhibition of this enzyme could enhance the cytotoxicity of chemotherapeutics, such as cisplatin, towards these chemoresistant cancer cells, and therefore contribute to the reversion of these chemoresistance. Therefore, we should delve into molecular mechanisms behind chemoresistant and try to search for more aldehyde dehydrogenase inhibitors, because they are quite promising in terms of their therapeutic use. That would pretty much be it. Thank you for your attention, everybody.
Thank you very much. Let's move to the discussion. Are there any questions?
Yes, if I may. Now I'll be the bad policeman. Thank you very much for interesting presentation. It was also interesting for me. I'm not oncologist, so I learned new things, very interesting things about medical problem. But this session is dedicated to systematic reviews, and we didn't actually see the systematic review in your presentation. Could you tell us more about your design, about your methods because you mentioned that you analyzed papers. Could you tell us more about that?
Yeah, so as I mentioned on the beginning of the presentation, me and my peers from Student Science Club used PubMed and Google Scholar databases, limited article searches to the years 2019-2024, because this is a topic that's rapidly evolving. There is more data coming year by year, new molecular methods of assessment. So that's why we limited article searches to the years 2024. We conducted article searches separately with me and my peers, and then we basically combined our searches, chose papers that suit the topic that, in our opinion, presented this in a good way, and then also assess this topic with our tutors, basically.
Okay, I see. It would be highly recommended to present more your results of the search during the presentation, in your papers also, not only concentrate on the medical problem, on explaining the medical problem and etc., but the methodology, because this systematic review is concentrated on this design, this study, and what other authors investigated and combined their knowledge and presented this one.
I understand.
Very true. Usually in published systematic reviews, meta-analyses, the results themselves are no more than 10, maybe 15% of the article. In fact, majority is just with a methodology. And it is for a reason. However, I would like to ask you a question while doing your search. We will not call it systematic, because it was not systematic. But while doing your search, did you find any articles that went, or studies that went past the preclinical phase, or is it just preclinical data?
Most of it is, so most of the data mainly on the inhibitors that I've mentioned at the end are being tested in vitro, so on cell lines, so the isophilocyanates, diamate. However, disulfiram actually went through the stage 2 and 3 of clinical studies. So disulfiram is being used actually as an adjuvant already or can be used. So it went through the clinical studies.
You did not present that during your presentation. Can you tell us the name of those studies and when were they published? Because I do not quite recall that we are using disulfiram in everyday clinical practice of concomitant cisplatin in radiotherapy in non-small cell lung cancer patients.
So I can't speak of the topic if it is used commonly in combination with cisplatin, because as you mentioned, it is not. But one of the articles from the years 2019-24 that I found mentioned that disulfiram went through stages 2 and 3, through phases 2 and 3 of clinical studies in terms of its use as an adjuvant with chemo, with cisplatin, and there are numerous studies which we have not referenced that also mention its use as an adjuvant with cisplatin.
Yeah, in general, you didn't mention those phase 3 studies or 2 studies. Could you once again say what year was it published in?
The particular article that mentioned that disulfiram went through stages 2 and 3, if I remember correctly, it was 2020 or 2019.
Okay, so that's the publication of the phase 3 study, right?
Mm-hmm.
Okay, I actually doubt that. So, but interesting, you said adjuvant cisplatin. Could you tell us what's the current standard of care adjuvant treatment in patients treated with concomitant chemoradiotherapy with cisplatin for advanced non-small cell lung cancer? What's the current standard of care in adjuvant treatment?
So it mostly depends on the stage of cancer. So if non-small cell lung cancer is diagnosed...
Advanced.
In advanced, I can't exactly recall the standard of adjuvant.
PD-L1 inhibitors. We don't use cisplatin adjuvant treatment for advanced lung cancer patients with non-small cell lung cancer. So that's why my question, we can't use it in adjuvant because we're not using cisplatin in adjuvant setting in those patients. But I would be interesting to see if that study actually exists, that phase 3 trial, and if it's positive, because I do not recall it. Thank you.
Mm-hmm. Thank you.
Thank you very much for your presentation. Okay, I think we can move to the next one, which is the effectiveness of the anti-hemorrhagic palliative radiotherapy for advanced gastric cancer patients.
Esteemed jury, ladies and gentlemen, I'm Anna Kozub, a medical student from Medical University of Silesia and also a volunteer in National Institute of Oncology in Gliwice. Today, I would like to present you the results of our recent systematic review study. To begin with, gastric cancer harbors the 4th highest mortality rate of all neoplasm across Europe. The diagnosis often occurs in late stage of disease due to some non-specific initial manifestations. Moreover, the prognosis for patients with advanced stage of this cancer is very poor because it's established of about 3.1% of 5-year estimated survival rate. And also further complication, as you can see, can be severely symptomatic. Today, I would like to focus on this bleeding complication. And according to the guidelines, we can distinguish between the acute and chronic blood loss. The acute one may be present as the result from the tumor and also as a consequence of therapy. In that case, we can use palliative radiotherapy. Also, we can use embolization or some other endoscopic treatment from interventional radiology. And for this chronic blood loss, it also occurs as a result of a cancer. In that case, we can use also this external beam radiation therapy issues. So, as there are not strict guidelines, we decided to perform this systematic review just to summarize this available evidence of the effectiveness of such treatment or palliative indication, and also to synthesize this acquired data in the form of systematic review. Firstly, we established our methodology protocol, and we also used and registered our future work in Prospero Registry for systematic reviews. And our systematic review was conducted between December, January, and February of this year. Our research question was in accordance to the title of my presentation. We wanted to focus on the effectiveness of such palliative radiotherapy action. And it was established due to this PICOS framework. We decided to include only prospective and retrospective studies with or without control group. However, as it occurred later, there weren't any studies with control group as it is palliative treatment. And also we didn't have any comparison for such kind of study due to palliation. Then we decided to perform our search in 4 databases. We use Medline, Embase, Scopus, and Google Scholar top 100 of hits, because after this initial search in PubMed, Scopus, and also in some journals from huge medical conferences across the world, it occurred that some journals are indexed only in, some smaller journals are indexed only in Google Scholar, and it was important for us also to include those data. And our search strategy included only English language articles, but without publication date filter applied due to the amount of these articles. Like we worked separately on this whole methodology part, and any arising conflicts were resolved by our tutor, just to have the consensus at the end of the methodology. As you can see, we have also our Prisma flowchart from about 4,000 of articles. We excluded the articles non-English, all case series, and commentaries, also and with not full text articles. Then we had about 400 for assessment for eligibility, when we excluded all guidelines or reviews, or some further stages of prospective trials as well. And finally, we included 44 articles. There you can also see our final search strategy for Medline, as we had to divide our search for 3 main groups: for the stomach neoplasm, for the intervention of radiotherapy, and for this palliative intent, such to have it all covered. Also, we performed risk of bias assessment using this iRobins tool. And all potential lapses that were found, they were due to the selection of patients for the methodology, and also not established exact follow-up periods in some of them. Now let's move on to the results section. The majority of the patients, because we have a lot of articles, so I cannot present it in the form of a table, so I'd like to say something about the main trends. So the majority of our patients were diagnosed with adenocarcinoma of the stomach. They were males, aged belonging to this elderly group, presenting symptoms not only for bleeding, but also for pain or pyloric obstruction. And what's interesting, majority of the studies was conducted in East Asia, in Japan, or in South Korea. The number of patients in the study group varied significantly between 15 and even up to 120 for some multi-center analyses. And the fraction size, they were also varied. However, the significant thing was that they were all fractionated, because our patients often are cachectic patients, so for their good is just to minimize the dosage during one session of radiotherapy, and the most popular scheme of 30 grays in 10 fractions. Then we observed that there were different follow-up periods in the studies, with the most popular time frames of day 7, day 13, and 2 or 3 months. And the follow-up periods often ended with the death of the patient, because they were symptomatic, and even if this blood ended, so this advanced stage of the disease just made its work. Then the mean time without bleeding was found to be between a matter of half to even almost 4 months of the follow-up. And the palliative effect was also most commonly for the first time reported during the day 7. However, it was stable to the end of follow-up for up to 80% of the patients. However, as I said in the risk of bias section, I think that's safer to say that good statistically significance is for about 60 to 70% of the patients with this effect, and for this 85 we had little issues if we could recall it as also a significant result. The survival of the patient also varied, most commonly about 4 months, and correlated with the heights in hemoglobin levels. As well, the decrease in amount of reduced transfusion. On average, we had the attempts of transfusions reduced after this radiotherapy treatment. And just to conclude, we can say that as for our patients, it could be a safe option for treatment, and it's also a significant finding for clinical practice, so we can perform it to help the patients in a palliative way. Thank you very much for the attention.
Thank you very much for your work. Let's move to the discussion. Are there any questions?
Congratulations on a good job.
Thank you.
Very nicely described methodology and correctly used tools and well-described results. This is the first paper bearing the hallmarks of a systematic review in our session. Good job, thank you.
Thank you very much.
Are there any other questions?
Yes, compliments for the authors and for the tutor as well. Fantastic job, and indeed you made a true systematic review. And also, not only methodology is excellent, but you also created a reference point for the other clinicians who think about maybe designing a study or have a reference point in their patient management. So everything is excellent. Could you please tell maybe other students 1 or 2 sentences, what were the greatest challenges? Because there were only 2 of you in this project. What were the challenges with Prisma and systematic review, proper systematic review design?
Thank you very much for your nice words. Yeah, as for the challenges, as you said, the biggest challenge was to find the time to perform all of these steps in accordance to all of established methodological all attachments found in the literature that are needed to perform it well. However, it was, I think, a good time of the year because it was between the December and February, so we had a lot of time during our winter break to sit and perform it day and night to have it completed in a good point of time, because we couldn't also focus on the methodology for half of a year. So after we had the registration in Prospero, we had to just type there for how many time we plan to do every steps of this, to conduct this research, and then we had to think of these time frames and work properly. However, well, if you know that this paper can change something, it's needed in the literature, so it's a high motivation for us to conduct it and continue our work.
Thank you very much.
As far as I remember, during that time, there's also session.
Yeah.
So fantastic work, and please think maybe about workshops for students, students for students.
Thank you very much.
Okay.
Okay, let's move to the next presentation, which is the prognostic and therapeutic significance of expression of CTLA4 in CLL, a review of recent reports.
Good morning, everyone. Can you hear me and see me well?
Yeah, we can see you well.
Okay, so I will share my screen now. Okay, can you see my presentation?
Yeah, we can see your presentation. However, can you do it on the full screen, because we also see your computer, like, oh, yeah, like this. Yeah.
Okay.
Perfect. Thank you very much.
So my name is Alicja Maziarczyk, and I prepared a study about the prognostic and therapeutic significance of expression of CTLA4 molecules in CLL. And to begin, CLL involves clonal proliferation and accumulation of major B lymphocyte cells in the blood, bone marrow, lymph nodes, and spleen. And it is often initiated by the loss or addition of large chromosomal material, which is then followed by additional mutations that make the leukemia increasingly aggressive. And it is one of the most common types of leukemia, which mostly affects elderly people. So a few sentences to start. What is CLL? And then what is it, CTLA4? So it is a cytotoxic T lymphocyte-associated protein 4, and it belongs to a family of immunoglobulin-associated receptors that are thought to regulate T cell function. And it is a co-inhibitory molecule that is expressed on T lymphocytes. And its main functions are to inhibit T lymphocyte function and maintain immune tolerance. And on regulatory T lymphocytes, it is expressed constitutively, and it provides their immunosuppressive effects. While on, it was on regulatory T lymphocytes. I'm not sure if I said regulatory or conventional, but on conventional T cells, it is expressed only after their activation, and it affects then cytokine production, cell differentiation, migration, and like intracellular interactions and so on. And the aim of our study was to present the prognostic and therapeutic significance of these molecules in CLL. And including materials and methods, we collected data from Midline database from the period 2017 and between 2017 and 2024, and by searching following keywords such as CLL, CTLA4, and anti-CTLA4 monoclonal antibodies. And coming to results, firstly, numerous studies showed that CD4, CD8, and regulatory T cells from CLL patients are characterized by increased expression of both surface and cytoplasmic CTLA4. And it has been also shown that these patients display elevated levels of CTLA4 on activated B cells and memorized B cells. And this indicates that the development of CLL enhances the induction of this gene, of CTLA4 gene, in peripheral T and B lymphocytes. And this may imply a strong suppression of T cell effector function. And next, I would like to move to CTLA4 as a prognostic factor. And it has been shown that the increased expression of these molecules on T cells in CLL patients appears to be a negative factor because it inhibits anti-tumor immunity in patients. And also another study confirmed that this increased expression of CTLA4 on CD3, CD4, and CD8 lymphocytes was associated with a worse disease course among CLL patients who were concurrently infected with EBV virus. However, this study shown no such relationship for EBV negative patients. And also in the same study, patients with high CTLA4 expression showed an increased risk of faster disease progression after diagnosis. They also required faster initiation of treatment, and their disease progression was simply more rapid. And at the same time, the higher level of CTLA4 expression in CLL cells is actually associated with a better clinical outcome, which means an earlier stage of the disease and lower levels of leukocytes and lymphocytes in the blood. And it has been also shown that a lower expression in CLL cells correlates with a significantly shorter time to treatment and a worse prognosis overall. So the level of CTLA4 expression can be both a favorable and unfavorable factor for patients, depending basically on the localization of these elevated levels. And now I would like to show also if CTLA4 can be used as a therapeutic factor in CLL. And antibodies that block the CTLA-4 molecule have found use in cancer immunotherapy, and the greatest activity was shown in metastatic melanoma. And we found one study that differentiated the efficacy of CTLA-4 blocking monoclonal antibodies in CLL patients according to the level of CTLA-4 expression on CLL cells. And this study showed that in patients with high CTLA-4 expression, blocking CTLA-4 induced pro-survival signals in CLL cells. So these antibodies were unsuccessful for them. However, in contrast, in patients with low CTLA-4 expression on leukemic cells, this CTLA-4 blockage did not affect proliferation and apoptosis of these malignant B cells. So this CTLA-4 expression on CLL cells may distinguish CLL patients in whom systemic admission of CTLA-4 blocking antibody can be beneficial and safe. And also, it has been recently shown that down modulation of CTLA-4 in vitro increases the proliferation rate of leukemic cells and increases surface expression of CD38, which is a marker for high-risk CLL. And it was also shown that CTLA-4 overexpression is associated with a better prognosis in CLL. So therefore, therapy targeting CTLA-4 is not advisable and may even be harmful in CLL patients because it can cause tumor survival and proliferation. So due to these researchers, I think that probably no further studies will be conducted on these monoclonal antibodies in this specific disease. And to sum up, CTLA-4 is obviously an important prognostic factor in CLL, and the level of CTLA-4 expression can be both favorable and unfavorable depending on the localization, as I said before. And also this efficacy of CTLA-4 blocking therapy may depend on the initial level of CTLA-4 expression on CLL cells. However, it may even be harmful in CLL patients and may result in tumor survival and tumor proliferation. And this is everything we prepared. These are our references, and thank you for your attention.
Thank you very much. I think we can start the discussion.
Thank you for the presentation. Hematology is not exactly my thing. However, I do have one question regarding the conclusions. It is a generally accepted rule for editors, for scientific journal editors, to see if there's anything in the conclusions that we would not know before starting to read the article. Other words, if there is no question answered by the end of our review, perhaps the review was not meaningful to start off with. So each of our conclusion is basically, it might be A or it might be B. It might be true or it might be not. Maybe it helps, but maybe it doesn't help. So maybe you could, in your own words, summarize it once again and tell us what is the information that we learned after listening to your presentation that we did not know before it started.
Okay, so yes, I think so. Maybe I said it too quickly, but I simply wrote this on the slide. So coming to prognostic significance, this elevated expression on T cells is simply a negative factor for CLL patients, and elevated expression of CTLA-4 on CLL cells is a good, favorable prognostic factor for CLL patients. Like basically, to sum up one sentence, and this therapeutic significance, I would like to say that it has been shown that blocking this molecule in CLL patients can be risky and probably shouldn't be performed because it leads to tumor survival and proliferation.
That is, by the way, that last part of your conclusions, that's the problem of causality. We should restrain from making statements that seem logical, but might just not be if the mechanism is different. Anyways, so I think the conclusions, written conclusions, could use some reworking, because right now they basically say it might be true, but maybe it's not true. Could you tell us something about how you performed the literature search?
Yes, so I am obviously sure it is not according to guidelines, so it's not a systematic review. But as I said, we searched the Medline database using these keywords, CLL, CTLA4, and then we also wanted to find something about anti-CTLA4 monoclonal antibodies. And using this phrase, we got a lot of results, even after narrowing them by using specific years. So we got like 1,000 results, I think, and we didn't screen through all of them. But coming to this prognostic significance, we included only articles that were open access in English and that were original study, no reviews. And trying to find anything on CTLA4 monoclonal antibodies in CLL, we included only one article that was a clinical trial. So we also excluded reviews and like clinical cases.
Quick comments: a very bad practice to exclude articles that are non-open access, because most of the major scientific society journals are not open access, just like the Nature family, or for example, in my case, it would be the Radiotherapy and Oncology journal. It's also not open access by default.
Okay, so I think I got this wrong, because I probably didn't mean open access, but I meant the, I'm sorry, the articles we had access to, because we use this like online library through our university, but still there were some articles we simply couldn't read. But I understand this was my mistake.
Oh, okay, that's understandable. Thank you.
Thank you very much. Are there any other questions? If not, I think we can move to the next presentation. So, a review of inflammatory markers in Parkinson's disease and potential effect of FMT.
Thank you. Good morning. My name is Weronika Zając, and I'm here to present a review of inflammatory markers in Parkinson's disease and potential effects of fecal microbiota transplantation. Here, I focused mainly on the substance of my review, but I would like to mention that after implementing all the exclusion criteria, we chose 117 publications in English. They mention original research and case series. We excluded review articles. So the Parkinson's disease is a motor disorder associated with neurodegeneration. As we can see, the number of cases are constantly rising, and by 2040, it is predicted that there will be 10 million cases worldwide. The typical symptoms include motor symptoms, which are mainly caused by the loss of dopaminergic neurons in substantia nigra of Parkinson's patients. There's also a number of non-motor symptoms, but there's a number of non-motor symptoms which indicate the multisystematic nature of this disease, which are mainly associated with damage to the autonomous nervous system. Before the onset of motor symptoms, there is a latent period of 7 to 10 years, which is mainly associated with accumulation of alpha-synuclein in autonomous nervous system, mainly enteric nervous system. This protein is invoking inflammation in that area, leading to gastrointestinal symptoms. On top of this evidence, Bragg et al. Proposed a dual hit hypothesis, stating that the pathology of Parkinson's starts in gastrointestinal tract and olfactory bulb, as often loss of smell is also associated with this non-motor period. After several years, the pathology spreads through the vagus nerve to the central nervous system, leading to the association with typical symptoms. Before placing alpha-synuclein in all this, I would like to mention the gut microbiome-brain axis. It is a complex connection between these three components that influences many functions like digestion or immunological homeostasis, in the end involving cognitive and emotional functions. The third component, the gut microbiota, involves all microorganisms in the gastrointestinal tract. They perform many vital physiological functions like synthesis of short-chain fatty acids or control of immunological homeostasis. Here I would like to quickly mention the role of short-chain fatty acids in all this. They are products of metabolism of bacteria in our gut. They, among other things, possess anti-inflammatory properties, decrease the number of anti-inflammatory cytokines, and increased permeability of the epithelial layer in the intestine. So there is no widely described universal change in the gut microbiota of Parkinson's patients, but there are several described changes. For instance, there is a decrease in bacteria that produce short-chain fatty acids. There is an increase in such species as Enterococcus faecalis, leading to inflammation and causing decreased bioavailability of levodopa, the main drug for Parkinson's. And there is an increase in bacteria that increase the permeability of the epithelial layer and getting to the higher exposure to endotoxin, invoking inflammation. So all in all, in general, the changes in microbiota in Parkinson's leads to increased synthesis of pro-inflammatory markers, and this leads to increased synthesis of alpha-synuclein in Parkinson's patients. Again, there is no universal change in inflammatory markers in Parkinson's patients, but several cytokines are increased, like pro-inflammatory cytokines as well as anti-inflammatory cytokines, supporting the idea that there is a severe damage to neurons and inflammatory system is trying to reduce it. At the beginning, the cytokines are synthesized locally, first in the gut, later in the central nervous system. This leads to increased permeability of the blood-brain barrier, allowing immune system to pass through it. First, the innate immune cells release their cytokines, and later specific T cells and B cells. This is just a vicious circle of inflammation, finally damaging neurons so much that we have clinical manifestations of Parkinson's. Therefore, fecal microbiota transplantation arose as a potential treatment method for Parkinson's. This is the method of transferring entire fecal content of a healthy individual with its entire microbiota, and later transferring it to the patient, for instance, with Parkinson's disease. This method holds promise for inflammatory bowel disease and was theorized to be applied in Parkinson. So there are a number of studies that assesses the effectiveness of FMT. First, I will focus on animal models. There are a number of works that showed decreased levels of inflammatory markers in Parkinson's, as well as reduced amount of lipopolysaccharide due to increased quality of the microbiota of mice after FMT. Finally, Sun et al. Showed that there is a suppression of pro-inflammatory signaling in mice after FMT. On top of this evidence, several clinical studies were performed. It all started in 2019 when Huang et al. Published a case study showing that the severity of motor and non-motor symptoms decreased in a single patient. Later, Segal et al. Published a case series repeating those results, and he assessed patients with unified Parkinson's scales. 3 other clinical studies were performed, replicating and publishing similar data, and eventually in 2024, Brueggermann et al. Showed that the changes in motor and non-motor symptoms are long-lasting. In conclusion, inflammation may have a potential role in pathogenesis of Parkinson's disease. It is supported by the idea that the pro-inflammatory markers are increased in the blood, in cerebrospinal fluid, and substantia nigra of Parkinson's patients. Gut microbiota may have a role in invoking this inflammation, as there are universally described changes in this microbiota in Parkinson's patients. Eventually, the fecal microbiota transplantation holds promise as a potential direction for therapeutic intervention in Parkinson's disease. Thank you very much.
Thank you very much. We can start the discussion. Are there any questions?
Could you please tell us more? Very nice paper and very interesting topic. Could you please tell us more about your methodology? How did you perform this, let's say, scientific systematic review?
So the research took us actually 2 years. We performed it using Medscape, Scope, and UpToDate. Eventually, we used key phrases as Parkinson's disease and fecal microbiota transplantation, or neuroinflammation, or just inflammation. Eventually, the papers were published from 2000 to 2024. As I said, we excluded review articles, and exclusion criteria included language, included the review articles, of course, and we focus merely on research that were measuring the inflammatory markers and their influence of changes of those markers on Parkinson's disease patients and their symptoms.
And then you added to the results of the study, you added the results from the clinicaltrials.gov.
Excuse me, could you repeat the question? Because
I understood from your paper. Also, I have access to your paper, to the abstract in the abstract book. I understood that you also searched, apart from this research, you also searched separately in the clinical trial base.
Yes, yes, exactly. We also searched on clinicaltrials.gov and read all of the results of clinical trials that were published on FMT, influence of FMT on Parkinson's. I'm so sorry, I forgot. I didn't mention that, but yes.
That was a separate search.
That was a separate search,
okay.
Yes, correct.
Okay, thank you.
Thank you for the presentation, very interesting. I have two comments, actually a comment to what you just said. So you said you looked for articles in UpToDate and in Medscape and in Scope.
Yes.
Neither of those is a database. You have to remember that each of those is just a site where people write review articles about current state of medical science. However, none of those can be used as a formal source for systematic search. But it's still an effort to use free sources, that's not bad. With the clinicaltrials.gov, I would just like to point out there is no obligation for the researchers to post their results on clinicaltrials.gov. That's a site where you register the trial and you have to update the state of the trial, so whether it's preparing to launch, or it's accruing, or so on, so on. However, it's not a very good place to look for the results of the trials.
I would like to explain this. So when I was looking on clinicaltrials.gov, I wanted to look for ongoing clinical trials and finished clinical trials. And based on those information, I was looking for clear result based on those trials. Because that was kind of my point from which I could, gather the sources. I mean, maybe not gather the sources, but like a point from where I could look for the sources. Because I wanted to see how many clinical trials are there, whether there are many of those, whether there are little, and whether they are finished or they're ongoing as such.
Yes, it is a nice way to go through the number of currently ongoing trials, but you have to remember that that is just one registry for clinical trials. For example, the Dutch trials will have their separate registry. There is a separate registry for Chinese trials, for Japanese trials. Australian trials will also be registered somewhere else. So we're not actually keeping track of the ongoing trials worldwide. In fact, you're not even keeping track of all the European trials. Well, to say the least, it's not even a European database, registry, it's US-based. But it's a good practice. However, you cannot treat it as a source of information. It just gives you an overview of what's currently ongoing, but you should not look for results on clinicaltrials.gov.
Thank you.
Thank you very much for your presentation. And now let's move to the next one, Enhancing Precision and Safety in Spinal Surgery, a comprehensive review of robotic assistance and technologies.
Okay, so my name is Paweł Łajczak. I am from the Student Scientific Neurosurgery Club at the Silesian Medical University. And together today with my colleagues, we have prepared a comprehensive review on the application of robotic devices in the spinal surgery. So generally, spinal surgery demands exceptional precision due to the proximity to the neural structures and the risk of serious complications such as nerve damage or paralysis may occur. Robots are reported in the literature as improving the accuracy and precision of performed procedures. They have been applied in the most of the surgical fields, including general surgery, urology, and this review aims to analyze the current state of research of this technology. I would like to begin with brief history. The robots are with us in the surgery since 1980, since the Puma robot system was used for the Brian biopsy. So it was also used for the neurosurgery at the first. However, the first application commercially available in the spine surgery was done by the Israeli company Mazor, which produced a spine assist robotic system in 2004. Now, robotic devices are being more and more advanced to the imaging technologies and implementation of artificial intelligence. We have performed a search through the PubMed and Scopus databases with keywords such as robot, robot assistant, and spine surgery. Initially, our result yielded 1,500 results from the PubMed database and 1,300 results from the Scopus. To analyze the current trends, two authors have independently searched with a specific. We have found out that the major application in the reported surgeries were the spinal fusion surgeries. This surgery involves the permanently jointing two or more vertebrae to prevent possible movement between the vertebrae. They are being most commonly used to treat conditions such as disc herniation, pathological scoliosis, or spinal stenosis. Robots are reported to be more effective in terms of precision and risk of complications. I will bring up an example how such device looks. Mazor X is one of the most commonly used devices in the spine surgery. It's also used in Poland. It was applied first in the Tarnów Hospital. It's an advanced robotic system which uses over 3 cameras for the imaging and the graphical user interface to accurately analyze the projectile and guide the pedicles in the process. Results in the literature are encouraging for the application of the implementation of robotic system. First of all, a major meta-analysis conducted by Naik and his colleagues in 2023 comprehensively analyzed over 127 studies and 77,000 pedicle screws. They showed that robot-assisted technology was superior to the fluoroscopic techniques, showing an accuracy of over 97.5% of the screw placement. Additionally, reports from the meta-analysis suggest lower complication rates compared to the manual techniques. For example, Wang et al. In 2024 conducted a meta-analysis where they compared a single screw placement time. Generally, major bleeding occurred lower in the robot-assisted procedures, and this result was statistically significant. Robots also proven to be comparable, or even in specific terms, have lower operation time compared to the manual techniques. Additionally, as mentioned before, blood loss and requirement for the additional blood transfusions is lower in the robot-assisted procedures due to the minimally invasive approach. Additionally, meta-analysis by Yang and his colleagues from 2024 showed promising results in the long-term patient outcomes. Meta-analysis of 20 studies suggested encouraging long-term results compared to the fluoroscopic techniques and other manual. However, the major drawback of the robot-assisted technology reported by cost-effectiveness meta-analysis are the initial cost of the purchasing such robots, as they can cost up to $1 million. However, the long-term work suggests that this is a long-term investment as potential number of complications, long-term patient outcomes, and screw accuracy placement allows for minimization of additional procedures compared to the standard methods. The future of robotic in spine surgery also holds a promise due to the currently implemented artificial intelligence. A semi-autonomous or even fully autonomous surgeries could even more improve the accuracy of the screws. Additionally, artificial intelligence is already guiding the surgeons in terms of navigating the screw. As mentioned before, the major challenge currently is the costs which are required for purchasing such robots. So some patients might not be may not be encouraged by the application of the robotic systems and would still prefer traditional conventional surgery. Robotic assistance in spinal surgery significantly enhances precision and safety, reduces complication, and promotes a philosophy of modern neurosurgery, which ideally should be minimally invasive. Despite benefits, adoption of robotic systems is hindered by high cost and extensive training, which is required for the surgeons to minimize potential complications, which could result from wrong use of the robots. And ongoing advancement in technology, including more advanced virtual reality, mixed reality, and artificial intelligence, will further improve the accuracy of this technique. Thank you very much.
Thank you. Let's start the discussion. Are there any questions?
In this case, I would have a question.
Sorry?
Okay. So my question is, you mentioned that you did a literature research, which I believe was non-systematic. However, that's not important. Well, let's be clear. At this point, you're okay with narrative reviews too. But you said you selected most significant and groundbreaking articles. How was the selection performed?
We have analyzed over 40 meta-analyses from the PubMed database, and we have reported the newest meta-analysis.
Not the best quality, but the newest, right? Because you mentioned most significant, not the newest. So which one was it?
The newest meta-analysis.
Okay, so it was not most significant and groundbreaking, it was the newest.
Yes, newest meta-analysis to report the...
Okay, okay. In this session, optimally, we would like to see your own meta-analysis, not one you found on PubMed. However, let's move forward. You posted a couple of conclusions. However, in meta-analysis, it is very important to appreciate the quality of evidence which we put into the model. The model is very simple mathematical equation, in fact. So let's talk about the long-term outcomes. You said robotic surgery improves long-term clinical outcomes based on 20 of studies. Could you define what type of outcomes were assessed and what kinds of studies were included? By that, I mean cohort studies, phase 1, phase 2, phase 3 studies, were they randomized? If they were randomized, were they blinded? So the quality of evidence.
This was inclusion of a meta-analysis of the randomized controlled trials comparing the robot-assisted technology to fluoroscopy techniques. And they compared mainly the post-operative infections and potential requirement for the correction surgery.
Okay, but you mentioned in particular long-term clinical outcomes, as in non-safety but efficacy. So what efficacy outcomes were assessed?
Can you repeat?
Yes, I'm talking about the slide, not the one in which you talked about the safety and the precision, but the clinical outcomes, efficacy. You mentioned that there's improved efficacy. The outcomes are better, not the safety, the outcomes. So I'm wondering what outcomes are improved when we do the surgery with a robot instead of an open surgery? Okay, perhaps in this case, maybe I misinterpreted the slide. You mentioned that one of the limitations is the costs. Did you try to calculate, or some of the authors evaluate the cost efficacy. It's quite easy to calculate if you
generally,
take that.
meta-analysis report that around 800 such surgeries have to be done per year to system measure X be cost effective.
Based on what premise? How was that calculated?
So generally, mostly it was calculated the requirement for the additional surgeries, which were derived from the inaccurate screw placement.
Okay, well, we use measures called number needed to treat, number needed to harm for those evaluations. Let's say treatment A costs $10,000, treatment B costs $20,000. We have to show it's more efficient or it has less adverse events. It can be calculated. So was that perhaps done? The increment in cost, was it calculated against the decrease in the toxicity? What I'm leading to, if you produce such a definitive conclusion that it is better, more safe, more precise, and so on, there has to be some data behind it. We cannot say that something is better, but not provide a specific reason why it is better. Okay?
Okay.
Thank you for the presentation.
Thank you very much. Are there any other questions?
Daniel? Can I go ahead? Very interesting presentation, and we can tell that you're fascinated by the topic. Of course, it's a very specific and still very new area, so that determines also your work. My suggestion is for you only to concentrate more on more narrow area, because I think you looked at those papers in a very wide manner. You looked at cost effectiveness, you looked at safety issues, you looked also at the aspect of precision. So you were a little bit lost, maybe because of your fascination, in what exactly you want to measure and in what exactly you want to verify. So I think just think about one or two aspects that you want to investigate, and that you will have a good recipe for the work.
Thank you.
Thank you very much. Okay, I think it's the end of the discussion. Thank you very much. Okay, and let's move to the next presentation, which is the role of mesenchymal cell-derived extracellular vesicles in regulation of the inflammatory process.
Ladies and gentlemen, esteemed members of the committee and the audience, I am delighted to have the opportunity to present the work entitled "The Role of Mesenchymal Stem Cell-Derived Extracellular Vesicles in Regulation of the Inflammatory Process." Now, on to a brief introduction to extracellular vesicles. They are a heterogeneous group of particles released by cells, such as mesenchymal stem cells, neuronal cells, endothelial cells, and epithelial cells. They are excreted both in pathological and physiological processes, and may be found in blood, urine, saliva, synovial fluid, and they exhibit low immunogenicity and toxicity, and their ability to bypass the blood-brain barrier makes them a better therapeutic agent than stem cells. The aim of this review was to determine the anti-inflammatory properties of mesenchymal stem cell-derived extracellular vesicles. And the material and methods we used was searching the PubMed and Google Scholar using keywords exosomes, extracellular vesicles, and inflammation. The search resulted in 712 papers, 25 of which were deemed suitable for this review. Our criteria was papers to be written in either Polish or English between the years of 2017 and 2024, containing our keywords. Now, on to the methods used to separate the EVs. The EVs are separated by ultracentrifugation, ultrafiltration, size exclusion chromatography, or microfluidic techniques. Next, the obtained vesicles are identified using transmission electron microscopy, nanoparticle tracking analyzers, or flow cytometry, amongst others. The samples may be dyed in order to ensure distinct visualization of the structures. Next, a brief introduction to the inflammatory process, which was the objective of this review, and is the body's natural response to harmful stimuli, characterized by 4 key features, including redness, warmth, swelling, and pain. The MSCVs have an effect on different cells of the immune system, including modulating the cytokine profile of dendritic cells, modulating the phenotype of macrophages between phenotypes M1 and M2, immunosuppressive effects on natural killer cells, as well as inhibiting the B and T cells, and increasing the proliferation of regulatory T cells. Now, onto the possible applications of MSC-EVs in medical settings. The first example refers to sepsis-associated liver dysfunction, SALD, which is caused by a complication in sepsis and inflammation leading to impaired liver function. The levels of IL-1 beta and IL-10 were measured in mice exhibiting the SALD symptoms. The mice were treated with MSC-EVs. It was observed that the levels of IL-1 beta were decreased in mice receiving the MSC-EVs in comparison to the LPS-only stimulated group. But in turn, it was found that the levels of IL-10 were higher in mice receiving the MSC-EVs than in the control group. Another example refers to Alzheimer's disease, which is a progressive neurodegenerative disorder caused by neuroinflammation. An application of MSC-EVs into mice exhibiting the Alzheimer's symptoms resulted in a decrease of the population of inflammatory microglial cells, IL-1 beta, and TNF-alpha. Furthermore, it resulted in an increase of the population of immunomodulatory microglial cells, IL-10, as well as TNF-beta. The next sample refers to acute graft versus host disease, GVHD, which is a complication of a stem cell transplant characterized by an intense proliferation and release of the T cells, cytotoxic T cells, and TH cells. The peripheral blood T cell subsets were analyzed in mice receiving the MSC-EVs. It was found that the therapy resulted in a decrease in the population of CD4 and CD8 cells, which suggests the immunosuppressive effects of MSC-EVs therapy in GVHD. Another example refers to acute lung injury, which may be caused by inflammation or infection, leading to impairment in the oxygen exchange and respiratory function. It was found that an application of MSC-EVs into mice exhibiting the ILA symptoms resulted in a decreased neutrophil infiltration and decreased levels of MIP2, suggesting in the alveoli, suggesting the anti-inflammatory effects of MSC-EVs in ILI. The next example refers to corneal scarring, which may be caused by inflammation, injury, or infection. The exosomes from immortalized MSC line were used. And next, after 24-hour mark and 48-hour mark, the levels of IL-8 and MCP1 were observed decreasing. The level of CXCL was observed decreasing at a later stage of the experiment after longer than 48 hours. This suggests the role of MSC-EVs in aiding regeneration of the cornea. The next example refers to dry eye disease, which impairs the vision and leads to impairment in vision. The use of human umbilical cord-derived vesicles resulted in lowered levels of CD4 cells, as well as an increased production of mucin, increased tear volume, as well as increased density of the goblet cells. In conclusion, the anti-inflammatory properties caused by the usage of MSC-EVs had been suggested by numerous studies, as the EVs affect the different cells of the immune system. Moreover, they possess a property of aiding the corneal regeneration, as well as improving the dry eye disease symptoms by helping to reduce the dry eye symptoms by increasing the tear volume. Thank you for your attention.
Thank you very much. So let's start the discussion.
Okay, go ahead. Right. Okay, so I'll go first, if I may. I have a very interesting paper. Thank you. All those papers are very impressive. I have a question regarding the selection criteria.
Well, I may have mentioned it before, but we used papers written in Polish or English, using keywords exosomes, extracellular vesicles, and inflammation via PubMed and Google Scholar. Does that answer the question?
So the keywords and the language were mostly the criteria for...
Yes, as well as the years of publication between 2017 and 2024. As this is
you didn't concentrate on any medical domain or, I don't know, preclinical model, because you mentioned that some studies were conducted on mice, some studies I think were conducted on pigs.
Yes, I definitely mentioned mice and rats, as it was mostly a preclinical model.
And you didn't. You had different medical domains, ophthalmology and I think others, right? Or in your conclusion, you mentioned cornea diseases.
Yes, that is correct.
But you didn't define it at the beginning, the medical domain and discipline, where you looked at.
Yes, that is my mistake, because we chose to concentrate on the inflammatory process, and then we found that it is connected to a wide plethora of disorders.
Okay, I see. Thank you very much.
Thank you.
Quick question. Was the corneal scarring something you found along the way, or was it to address the question of whether mesenchymal stem cell-derived ACVs can be used in the treatment of corneal scarring? Was a question you formulated before you started the review?
Yeah, I mean, it was premeditated and an integral part of the presentation and an object of our...
So that was a question you formulated before you doing the literature review? Or no? Or was it something you found along the way?
Yes, I think we found it along the way because it directly connects to the inflammatory process, which was the main objective.
So the idea, the presentation was very nice, by the way. You're presenting really well. So that's really good. But the idea of systematic reviews is to formulate a very specific question, something that has been addressed by many studies, and then gather all of the evidence, not only the positive evidence. Actually, the most important part of the systematic reviews and meta-analysis is to also provide the negative evidence, because sometimes the selection or the publishing bias might cause some findings to surface because multiple phase 1, phase 2 negative studies are just never published. So that would be my one comment, that it's good to formulate a question and to focus on answering a question, and that to identify a question is done through the initial literature reviews. A hypothesis without a literature review is not a hypothesis, it is a guess. So to formulate a hypothesis, for example, the MVCs help in the treatment of corneal scarring, that is a hypothesis which you formulate after doing the initial research. So I would say that was probably the initial search. Okay, thank you.
Thank you.
Oh, by the way, you formulated a clinical conclusion. Were there any studies on humans?
No.
Okay, so also be careful with formulating clinical conclusions on preclinical studies.
Thank you very much.
Thank you very much for your presentation, and now let's move to the next one, neuroscan advancements in deep learning for brain stroke identification.
Hello, can you hear me?
Hello, can you do whole screen presentation, please?
What? Can you repeat, please?
And we barely hear you. If there is a possibility to do it louder, so it will be perfect. Okay, we see now whole screen presentation.
So, okay, wait a second, please.
Okay.
Now I have to start.
Yeah, if you are ready, you can start.
Hello, my name is Alexander Kalin. I'm from Romania, and today I will try to present my little work, neuroscan advancement in deep learning for brain stroke identification. So, how to yes, in the summary of my presentation, introduction, results, material, method, and conclusion. So to get started, deep learning is artificial neural network that try to imitate the human intelligence, and deep learning use a lot of variation algorithms that are significantly helpful for various domains, offering effective solutions to complex challenges. To this review, we aim to provide researchers and clinicals with insight into the current state of the deep learning-based ischemic stroke segmentation and its potential clinical implication in future research to direction in this rapidly evolving field. The classification of artificial intelligence architecture, artificial intelligence, AI, machine learning and deep learning, which is the similar. It's trying to reproduce the human intelligence. So, what about stroke? It's a medical emergency. It is caused by interruption of blood supply to the brain, and it is characterized by deprivation of oxygen and nutrients to the brain cells, and due to the high mortality and disability, this represents a well problem. So, material and methods. We use Embase, Medline, Science, and PubMed for our study. And furthermore, I use 13 articles published in our database. Sorry, I can
are you there with us, or hello? We will give you 2 minutes, and if not, we will proceed to another presentation, okay?
Mr. Alexandro said that he will be in a minute.
Okay, I think we will wait this minute.
Now we have, I will just give you the information we received from Mr. Alexandro. 1 minute, so can we have 1 more minute?
course, we can. In the meantime, I will say that you are all cordially invited to all workshops at the Medical Simulation Center and to the lunch, which is at 12 o'clock here in the registration center. And we'll wait 1 more minute. If not, we'll proceed to the next presentation. Okay, I think we can proceed to the next presentation because we are run out of the time. So the next presentation is Machine Meets Brain, a systematic review of effectiveness of robotically performed cerebral angiography.
So in this presentation, I would like to focus on the application of the robots in diagnostic cerebral angiography. We have conducted a systematic review about effectiveness of this technology. So generally speaking, every 40 seconds, someone experiences stroke in the United States, according to the heart disease and stroke statistics from previous year. Every 3 minutes, someone dies because of the stroke. 800,000 Americans die every year because of the stroke, and costs reach up to $57 billion on the rehabilitation and the treatment. Over 30% of Americans have more than 1 hour drive to the closest neurointerventional medical center, what complicates things even more. The gold standard in diagnosis of the cerebrovascular incidents is diagnostic cerebral angiography, which allows through the injection of contrast to assess the blood vessels and determine the pathological creations in the brain. However, this technology, this intervention has some drawbacks, which include, for example, radiation to the surgical staff, as surgeons are exposed to the ionizing radiation. Additionally, another question is the ergonomics, which, due to the long standing, can create longer orthopedic-related degeneration. What is the solution to this problem? Robots. Robots have been applied in the various fields of the surgery, including more recently into neurointerventional procedures. In this systematic review, according to the PRISMA guidelines, we have searched databases such as PubMed, Cochrane, Web of Science, Scopus, and Embase. So generally, we intended to include intracranial inhuman procedures involving robot-assisted intervention. We have excluded not inhuman procedures, phantom, or extracranial studies. This search was conducted by 3 reviewers independently, and the conflicts were resolved by an expert in this field with more than 20 years of experience in the robot-assisted technology. Finally, after the synthesis, we have included 7 studies. We have used 2 tools to assess the bias. One was used for the randomized controlled trials, ROB, and one for the diagnostic studies. We haven't performed the grade assessment due to the very low number of studies, and I will explain later why. So here are the included studies. 4 of them were from the United States, 3 from the People's Republic of China. The most common used robotical system was CorePath GRX, which was initially created for the coronary interventions. Devices from the People's Republic of China, interestingly, used their own custom-made robots. For example, this VIR2 was created by Shanghai University. when talking about the access point, studies used various approaches such as femoral artery, radial artery, and one study even used ulnar artery. However, the number of patients in the studies was mostly low. 2 studies had more than 100 patients, and less of them had 40 patients. The most important trial so far was conducted by Liu and his colleagues in China, where they have performed a randomized control trial. Their trial between the robot-assisted angiography and manual performed procedures showed no statistically significant differences between procedure time, mortality, or success rate. However, we found concerns as this trial was performed without blinding. Now I would like to focus more on the CorPath GRX system, as it was most commonly used in the neurointerventional procedures. Here is a figure for this system. It consists of robotic arm and remote controlling unit, where interventionist has access to the steering and visuals, allowing for precise treatment. Generally speaking, as I said before, it may reduce radiation. In this case, actually, it's not showed, but this remote steering unit can be placed in a separate shielded room to reduce potential ionizing radiation, as well as I mentioned, the potential ergonomics, which are significantly better as surgeon can use sitting position. However, unfortunately and interestingly, the commercially available robot, the CorPath, showed us only complications in terms of manual conversions. They were mostly caused due to the difficult patient anatomy, limited working long of the catheter. As I said before, this system was initially designed for the coronary interventions. Additionally, cassette failures, robotic arm failure, and robotic procedure time too long was present. So we can see a heterogeneity between the results, between the randomized control trial and commercially available robots. What are the pros, cons, cost, and the future of these systems? I would like to begin with the advantages. As I said, the exposure to radiation for the staff is significantly minimized, what was proven in the most of the trials. This allows for the less exposure for the staff to which could lead to the potential development of neoplasm. Additionally, ergonomics are the major benefit for the surgeon itself, and randomized control trial showed no differences in terms of success rate. However, notable heterogeneity is present among the results. Manual conversions which are present in the commercially available results raise a question how in reality such system is effective compared to the custom-made devices. Also, some studies, such as COSTA, reported which compared the CorPath system to the manual technique, that the procedure time was too long. Another question is the cost. As robotic system, CorPath GRX cost $600,000. This might be initially discouraging for the hospitals to implement. The future involves implementation of artificial intelligence techniques and more advanced imaging types. Additionally, the main point here is to start conducting randomized trials on the commercially available systems to determine potential cost effectiveness of this method. Thank you very much.
Thank you very much. Let's move to the discussion. Are there any questions?
Very nice presentation. That was, in fact, a systematic review. Or at least you came very close to it, which is very good, very commendable, and that surely scores high during today's session. So I'll have a couple of questions, which are actually based on the Prisma checklist.
Okay.
First, could you tell us, was your systematic review registered?
We have not registered our systematic review.
Okay. You mentioned risk of bias analysis, which is really good. However, I don't think you mentioned the correct tools, to my best knowledge. Could you repeat what tools you used for the risk of bias assessment?
Risk of bias by Cochrane tool and quality in diagnostic accuracy studies was preferred for the non-randomized trials.
Oh, okay, because I've heard great, but that's something different. Okay, so that's correct. So could you tell us more? I am assuming you performed the risk of it's actually Cochrane's risk of bias version 2 tool. So since
yes,
2016. Could you tell us if you did the evaluation? Were there any concerning aspects of the study?
I will also add that, because I haven't mentioned that, our selection did not use any filters, such as language or the paper type or language. We have tried to include all of the papers. Now, moving on your question. So generally, the most common problem was the lack of clear inclusion criteria. Generally, the studies were retrospective in nature and haven't established any qualitative.
Let me just interrupt you. I'm talking about in particular that one randomized study. Did you do the risk of bias analysis for that one study?
Can you repeat?
Yes, the randomized study. You included one randomized study, right?
Yes, right.
Did you do the risk of bias analysis for that study?
We did separately for this study and separately for the non-randomized trials. And generally, as I mentioned, this trial had no concerns in the selection criteria and the general comparator. However, the major problem with this study was the lack of blinding.
So, do you remember what's the name of the domain which measures things like randomization and blinding?
Is it the first domain, patient selection?
Confounding.
Ah, okay.
Fine, but that's really good anyways. And could you tell us something about the risk of bias analysis for the remaining 6 studies?
For the remaining 6 studies, generally, as I said, the major problem was the lack of any selection criteria. That was the problem. Also, the studies have not performed, most of them, only 3 out of 7 studies in total, including this randomized trial, have compared the effectiveness of this technique. Also, I believe that the long-term outcomes were not fully reported, so generally this could create a bias.
Okay, thank you very much.
And I would like to add one more thing, because I said, I forgot to add, because of the high bias in the studies, we have not performed great assessment, which actually could evaluate the effectiveness and the potential results into the literature.
Thank you very much. Are there any questions more?
No, I'll have no questions. I have a question for my colleagues from the jury, if I may. If we can give a chance to Mr. Alexander. I know that we are running out of time, but we all had in the past and will probably have in the future technical problems. So if we could give him another chance. I don't know him. I don't have a conflict of interest. I would just like to hear the presentation. So if you're okay.
Okay, I think we can give him one more chance, but Dr. Marcin Miszczyk unfortunately must go, so probably you will just give the points for the presentation. If that's all right, we can move to the presentation one more time.
So a lot of things. I will be very, very briefly.
Yes, you can start if you're ready.
So I resume. So I review 30 articles published between 2019 to 2023, and the inclusion criteria was this article and research involving human stroke. Exclusion criteria, research involving animal data in an article published before 2019. So the basic architecture of a feed-forward convolutional and neural network. So in the results, this technological dramatically shortened the treatment duration. This improved rapid detection and treatment of stroke.
I'm sorry, but we see your first slide of the presentation. Are you changing your slides? Please upload your full screen.
You have to share your screen. I will stop it now, and please share your whole screen.
Okay. Again. Now.
Now we do not see anything.
No?
Okay, we see your presentation, not full screen, but it's okay, just change your slides. Oh, now it's perfect.
Okay. So, the result, deep learning dramatically shortened the treatment duration. This leads to rapid detection and treatment of the stroke. They are reducing the morbidity and mortality. Deep learning approaches still lack of interpretability, and many radiologists still possess skepticism on deep learning algorithm and lack of confidence in software-assisted diagnosis. The characteristics of the stroke lesion may depend on the image modality used, and deep learning still face many challenges for stroke diagnosis. As a conclusion, deep learning models have demonstrated impressive generation capabilities, enabling them to perform well across different image modalities such as MRI and CT. And this versatility makes them applicable in diverse clinical settings and enhance their potential for widespread adoption within clinical practice. And thank you, and sorry for all my mistakes. I was a bit nervous and
thank you very much for your presentation. Now let's start the discussion. Are there any questions?
I don't have questions. Of course, I think we all understand that sometimes technical problems appear. Please continue the topic. It's interesting, and it's also very new area of complementing the clinical research. So it's worth investigating. Thank you.
Thank you very much for this comment. And now all the submitted papers have been presented. Of course, we all congratulate for the presenting authors and participants of the systematic review and meta-analysis session 1. At this point, I would like to ask the Dr. Zembala John for a few words to sum up a session, please.
Few words. First of all, I think I speak on behalf of all members of the jury. Fantastic presentations, fantastic work. You have done fantastic work, a lot of efforts. We can see a lot of heart put in your work. So please continue what you are doing. Of course, some critical comments from, please treat us like your older colleagues. Some recommendation, what is exactly a systematic review? There are specific standards, there are specific guidelines, please follow them. It's a great challenge, it's difficult, we don't deny, but it's worth to follow those guidelines and prepare it according to to those rules. Please also remember what are you writing in your studies. I noticed that there is a great difference in your aims, in your title, and in your conclusions. I think it's because you are, frankly speaking, you are fascinated by the topic, and you concentrate along the way, in your work, on different aspects, sometimes forgetting what was your aim. So please stick to the aim and the title that you said at the beginning. But in general, we are all impressed by your work, tremendous effort. So once again, congratulations and good luck with your further work. Please remember also to publish your results in the future. Don't put them in a drawer. Continue your work.
Thank you very much for these words. We truly appreciate your valuable comments, accurate observation, and work on presentation assessment. We would like to cordially invite you for the decoration and closing ceremony of the SIMC 2024 conference, which will be held in the Theatre Rialto on the 17th of May at 6 p.m. Thank you very much.